We can have the video so that everyone can see. Yeah, please play it.
देखो इन्हें ये है ओस की बूंदे पत्तों की गोद में आसमां से कूदे अंगड़ाई ले फिर करवट बदल कर नाजुक से मोती हंस दे फिसल कर खो न जाए ये तारे ज़मीं पर।
Congratulations to all the miracle makers. And on this auspicious day of World IVF Day Eve, I invite ISAR President Dr. Amit Patki and Secretary General ISAR Dr. Ashab Bakshi, our revered chief guest Dr. Sunita Tandulwadkar, Madam. Can I have CV of President ISAR, please? It is an honor to introduce Dr. Isar Patki, Dr. Amit Patki, Isar President. And after that, Manisha, I think you can take us through the program.
Sure.
Dr. Amit Patki is heading the largest organization of IVF specialists in India. Sir is the medical director of Fertility Associates in Mumbai and consultant at Khar, Hinduja and Surya Hospitals, Mumbai. He has kindled ISAR with energy and enthusiasm with multiple new innovative programs and guidelines. I've been fortunate to be a part of some of these. Sir holds the post of country representative of Aspire, governing council member of ICOG, vice chair MSR, chair West Zone RCOG, and president of Mumbai OBGY Society, with multiple publications in national and international journals, more than 100 book chapters, editorship of 3 books, 2 international patents in infertility and stem cell research, and a TEDx speaker. We welcome you, sir, and we would be honored to have your words in the program.
So, a very good evening to you all, and thank you, Monica, for this excellent ISAR Perfection series, which you have been doing, I think, for more than 2 years. And every time you come up with excellent topics, and more importantly, excellent speakers, and it's a very educative meeting. And I would like to thank Dr. Randir, Dr. Neelam, Dr. Garima, and Dr. Manisha, who have been helping you to coordinate this wonderful series. My congratulations to all of you, and my welcome and my regards to Dr. Sunita Tandulwadkar, our president at Foxy, who has kindly consented to be the chief guest for this webinar. So welcome, Sunita, and we applaud and we admire your work that you are doing across the length and breadth of India. And particularly, I'm amazed at the advocacy that you are doing with government on various projects. So, our heartfelt congratulations from all Is- Isarians, and we wish you the very best in Foxy. And we earnestly look forward to welcoming you as president in ISAR the next year. So thank you very much for having me, and best wishes to your series, Monica.
Thank you. Thank you so much, sir, for your address. And these words are very precious to us. Before welcoming our chief guest, I would like to honor and welcome Secretary General ISAR, Dr. Asha Bakshi, Madam. Madam is a well-known figure all over India, and she has been exceptionally active in ISAR. And I would like to Yes. Yeah, I would like to welcome Madam to the program. She is a pioneer of IVF in Madhya Pradesh, one of the beginning centers in India and in MP started from Indore, where Madam gave up, a plush practice in UK and moved to India. And I distinctly remember talking to her way back in 2001 when she said, Ki Monica, the happiness you get working in India, in your country, you cannot compare it with anywhere in the West. So, Madam, your words have stayed with us for all those years. And Madam has been active in all the possible organizations in FOXY, ISAR, in RCOG, ICOG, a very great academician. Always a helping hand to all of us. She is the person who involved me in the first randomized controlled trial of India under her leadership, in which she was principal investigator. She's done some wonderful conferences of national level in Indore. And we are going to have another ISAR Embryology in Indore in September under her chairpersonship, and under her patronage. And thank you, ma'am, for joining. We'd like to have a few words from you, madam.
Thank you, Monica, for such kind words, and you really spoke from your heart. And I've seen you right from the beginning, the time you came to my clinic to learn embryo transfer and everything, and today you are shining so well. And I think your webinars are excellent, and people are looking forward to attend your webinars. So that's the best thing. And my warm greetings to our president, Dr. Amit Patki, who is really doing dynamic work, and that work is evident everywhere, nationally as well as internationally. And I, with my folded hands, I welcome Dr. Sunita Tandulwadkar, our president of FOXY and incoming president of ISAR. And already Dr. Patki has told, and I think I really admire her energy, and I want to know what she takes to keep up. She is not only working for FOXY, but even her practice, she's not neglecting her practice. That is the biggest thing. So that's the biggest thing one can have, that you are active everywhere. And this Perfections Fertisphere series, today you have selected very good topic on RIF, and I think that's I think everyone feels very upset to with this particular topic, and I'm sure lots of things will be learned today. And I also welcome Dr. Laxmi, Shrikhande, Dr. Vijay, Mangoli, and nice to see our young Rohan also as a special guest. And of course, conveners besides Monica, my heartiest congratulations to Randir, Garima, Manisha, Purva, and Shweta, and I heard that Dr. Neelam will also join you in this series. So really keep up with the good work, and I'm sure Dr. Manish Banker, you and all the speakers are really going to do good to give us lots of points, and we'll learn a lot. So keep doing the good work, and wishing you all a very happy World IVF Day, World Embryologist Day. Thank you so much.
Thank you so much, ma'am, for those kind words. And now we come to the most awaited moment of welcoming and honoring our chief guest for the evening, who is none other than President of the largest organization of obstetricians and gynecologists in India, numbering over 48,000 now, Dr. Sunita Tandulwadkar, madam. President FOXY, let's put our hands together for madam for blessing our function. And she is also very, very happily the president-elect of ISAR. So she'll be taking over when Amit sir finishes his wonderful tenure. Madam will be stepping in as president of ISAR. Can I have Madam CV? I absolutely don't need Madam CV. I must have
Monica, can we avoid having CV, please?
Okay, ma'am.
No need of introduction. This is all our gathering, and everyone knows everyone. So thank you so much. For fiction series, when you asked, it was such a wonderful, because we started it 3 years ago. This is your third series going on. The first series we started, and you were my coordinator, and the way you were working, Monica, was fantastic. This perfection series coming out with the one topic and discussing in depth and taking the good faculty with it, I think is a very educational. And many of my fellows, even if they don't join because the timings usually are not comfortable, they always go and listen to this perfection series. So it's always because it's so highly valued. Today you have Manish speaking on a RIF. It's wonderful. Coming to ISAR always and will always be the rocking and has its own footprints in international organization also. But Amit Patki has taken it in a very different lead. The academic strength of ISAR is very palpable across the country, across all the states and the zone. And that's what is very, very important. Ultimately, reproductive medicine is just the academics. What we spoke 3 years ago, today probably we don't even practice. Our understanding of the subject increases. We evolve with our experience, we evolve with the technologies and the treatment for RIF. 5 years ago, what I prepared and what I will give today, I think there will be addition of 3 to 4 important factors, and I'm sure Manish will be talking with the evidences on that. Your team, you have a bubbly team, and that's what the ISAR is all about. Manisha, you are too good a girl, yeah. Though I don't know other people who are your team member. I know people, but who are your team members? I don't know. I see only Dr. Poonam also here, but I know whether in the picture or not, Randir is your by all the team member from the core. What seeing Vijay, seeing Lakshmi after a long time, it's such a great experience and a feeling. You feel like, last 6 months, or you can say 2 years. Hi, Sujata. Last 2 years, I'm so much involved into Foxy. And of course, I love and enjoy looking forward to Kanyakumari conference. But when you come to ISAR, it's a completely different family altogether, different bonding, different feeling. And that's what it is. The organizations give you beautiful families across, and these are your lifelong friends. Thank you so much for making a part. And though I will be muted and I will not be seen, I will be listening to this very important talk, because that's what again is. There is always one or two important points to be carried with, to implement, to read about, and I'm sure it is going to at least give few points to each and everyone who have joined. Thank you for making me a part of this, and Asha, definitely thank you for your lovely words, and definitely I'll send the video across to you. Thank you.
Thank you.
I
Thank you.
don't
Thank you,
leave
Sunita
the
ma'am.
practice that is so important. That is so important. Now also I'm in my clinic watching on the screen what is happening, what is not happening all around me, because ultimately we enjoy when we are with patients. I think that's the important moment of our life, apart from our family and organization. Helping and working with and having a dialogue with the patients, that is what reproductive medicine is all about, because everyone comes with the hope, and that hope makes you work harder. Thank you so much for making me a part, and love you all.
Thank you. Thank you so much, ma'am.
Thank you, ma'am. Thank you, ma'am. And we always expect from you that, madam, in coming next 26 2 years in ISAR, we'll be getting a new scientific things. And you have given, as you told, that we are very happy when we see the patient happy, and the stem cell therapy which you had started to the India and the world. I think we'll be working more on that. Thank you, ma'am.
I request all of you come to Mumbai for a ISHRE campus. Amit has taken a lot of efforts for that, and it's responsibility of each and everyone to be there, and then in Ahmedabad. See you.
Thank you, ma'am. Thank you,
Thank,
ma'am.
thank you so much, ma'am. And when we went to ICOG National Conference, my hotel was just above the Ruby Hall Clinic, Madam's Hospital. And every time we used to go and come back from the hotel, I used to just keep looking at it and took pictures of it. Oh, this is where Sunita madam works. And it's such a busy area. There are, trains going and traffic, and madam is working in that haven of, huge amount of Pune population, and her stem cell clinic, madam, I also saw over there. Thank you so much, madam.
Thank you.
Thank you so much for blessing us.
Thank you.
I've seen you working day and night, even with a fractured shoulder. I've seen the efforts you have put. I've seen you going without sleep, without food for your campaign, traveling thousands of kilometers within a span of 7 to 10 days, madam. So, whatever efforts we can put, you can put 10 times more than us. That is your energy level, madam.
Thank you, beta. Thank you.
Fully agree.
So, taking the program forward after madam's blessing.
All the best, Laxmi.
Thank you, dear Sunita.
So we start our, introductions and welcome of our guest of honor. Our guest of honor for the evening is Dr. Laxmi Shrikhande ma'am, another teacher and mentor to me, very, very dear to me. Right for the time, from the time we accidentally bumped in the train and madam was standing behind me, and to the day when she is contesting for some of the most coveted posts in elections, madam, all the best to you. Madam has been the past very illustrious chairperson of ICOG, and some of the best programs we have seen in ICOG. And I myself, under Madam's chairpersonship, I myself attended about 3 certificate courses of ICOG, Madam, and they were all wonderful. Besides this, Madam has been very, very active in Jogi. And being active and a national corresponding editor of Jogi means day and night work. We know the amount of work, hard work which goes into it, and the amount of academic excellence. Madam is also very active in the Association of Medical Women of India, ISOPA Vidarbha chapter, IMS Education Committee, and she was the chairperson of Fertility Enhancement Committee of ISOPA. Madam is basically an ART person, though we know her as a very, very great academician, but her heart is with ART. That is the subject which is very close to her heart. And that is why she has been awarded with the Nagpur Ratan Award from the hands of Gadkari ji. She has received Bharat Excellence Award for Women's Health. She has received Mehru Dara Hansotia Best Committee Award during her tenure as chairperson HIV Committee FOXY. She has received appreciation letter from the Maharashtra government for her tremendous work in the field of saving girl child. Madam has been a renowned orator and lecturer. She's taken hundreds of lectures and orations with several publications and is very passionate about sensitizing young children and adolescents about health issues. We welcome you, ma'am, with folded hands to Perfection 3.0 and would like to have blessings from you, madam.
Thank you so much, Manisha, for your kind words. Good evening, everyone. It's real pleasure to share dais with none other than Dr. Sunita Tandulwadkar, who is currently the sitting FOXY President-elect ISAR. But above all, she is a dear friend and a wonderful human being. A big thank you to ISAR, especially ISAR President Dr. Amit Patki. I fully agree with Sunita that Amit, you have really taken ISAR to a greater height, and you are ably assisted by Dr. Ashab Bakshi. Thank you, Asha, for having me here. And also, both of you continue to create such meaningful academic platforms throughout your tenure. I also must compliment Dr. Monica Singh and Dr. Randhir Singh, and also the co-conveners, Dr. Garima and Manisha. You have brought together the right mix of science, practical insights, and expert minds. And I love the name, Perfection Fertisphere. It really captures what we all strive for in reproductive medicine, that is precision, practice, and perspective. Recurrent implantation failure is one of those areas that test not just our knowledge, but also our empathy and persistence. For couples, it's an emotional roller coaster, but for us clinicians, it's a real challenge that pushes us to constantly rethink, reassess, and refine our approach. I am happy to see that today's program includes protocol-based learning and lab cleaning integration. I am really happy to see Dr. Vijay Mangoli and Manisha Vajpayee to share their thoughts with the clinicians, because they are the persons who are working behind the scene and they are the actual heroes for our IVF success rates.
Thank you so much.
I'm sure today's discussion will leave us all better informed and inspired. Thank you once again, Monica, for your kind invitation. And I look forward to learning with all of you today. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you, Laxmi ma'am. And we look forward to having a great talk from you very much in the near future. And you're very right. Manisha is like fire in my.
Yes.
She is such a enthusiastic girl and full of ideas. And she's opened new vistas of joint clinical and embryological approach in every webinar we do, which gets us together with so many new academicians and friends from the field of embryology. Now, I introduce to you one of the greatest leaders in the field of embryology, who is almost like the Pitama of embryology,
Yes.
Dr. Vijay Mangoli, sir. A person who is very, shy and in not away from the limelight, but we
Doctor.
know that just hides the great amount of light and the illuminance that he has. Sir has been Secretary General of ISAR in the year 2009 to 11, and also chairperson of Embryology ISAR, largest body of embryologists in India from 2014 to 16. Right now, he is laboratory director of fertility clinic in Mumbai, and he will complete 40 years in human IVF, 1986 to 2026 next year. He is a keen academician with several papers, more than 21 in peer-reviewed journals, more than 200 presentations in national international conferences, 51 chapters in medical textbooks, recipient of Lifetime Achievement Award in 2017, and holds a patent for indigenous vitrification device for cryopreserving gametes and embryos. We are so honored to have you, Mangoli sir, with us. And this program cannot begin without your blessings.
Dr. Monica, I'll say a few words for him because I am knowing him since last 25 years when I started ABCD of embryology. And I still remember when Sadhna Desai ma'am and they were in the Mumbai conference. And from my heart, I'll pay regards to you. And I consider you like B.N. Chakravarti of the Kolkata, his team, Ratna ma'am. You are from the Bombay, the core, and you are the embryology behind the team. You made the embryologist as a part of a success and a recognition to the whole society of India. Welcome, Vijay Mangoli.
Thank you, Ranveer. Thank you very much. First of all, it is such a pleasure to be here with you all today, and I'm genuinely honored to be invited as a guest of honor for this fantastic initiative, the Perfection Fertisphere series. Big thank you to Manisha and also Ranveer, you and Monica, not only for dreaming this up, but making it happen with such a passion. And of course, to ISAR for the supporting it wholeheartedly. Truly speaking, perfection is a pretty utopian word, idealistic, but often impractical. And in embryology, we chase it every single day, knowing it well that it may always be just a little out of reach, but still we try. Every embryo that we culture, every protocol we tweak, every dish we prepare, it's all with the hope that it will translate into that one precious outcome, a successful pregnancy. And that's why I find today's theme, implantation failure, so important and so timely, because we all experience that even when the embryos look textbook perfect, even when everything seems to be by the book, implantation can still fail. And that's when it really humbles us, making realize our limitations. It reminds us that reproductive science is not just lab work. It's a complex interplay of the molecular biology, immunology, genetics, and sometimes sheer mystery. So exploring implantation failure means looking deeper, not just at the embryos, but at the endometrial receptivity, at the embryo maternal dialogue, and yes, sometimes at ourselves and the assumptions we carry in our labs and also in the clinics. It forces us to think across the discipline, to listen more and to collaborate more. And that's why a series like this, Fertisphere, is such a breath of fresh air. It's not just a platform to share the polished PowerPoint presentations. It is a space for real conversation about what works, what doesn't, what we are learned the hard way, and what we are still figuring it out. It's where the experience meets the curiosity and where we grow as a community as such. So I would like to thank everyone present here for being the part of this conversation. The work you do matters, the questions you ask matter, and together I truly believe that we may get closer to answers that will help more patients cross that final and often frustrating hurdle, implantation. So let's keep striving, keep sharing, and more importantly, keep supporting each other through this ever-evolving journey of reproductive science. Thank you very much once again for this honor. It really means a lot to me. Thank you very much.
Thank you, Mangoli sir. And we would love to have an out-and-out webinar dedicated to you. And we'll do it very, very soon. Manisha and I, we've already planned the program.
Thank
So
you.
thank you for being
We learn from you. Being a good human being reflects everywhere.
Yes.
Thank you, Manisha. Thank you, Manisha. You're so sweet.
Thank you, Vijay Mangoli sir.
Thank you, Randeer. Thanks.
So now from the one of the senior most, the pioneers, we come to the young trailblazers, and that is none other than Rohan Palshetkar. Dr. Rohan Palshetkar is the special guest for evening, and I wanted him as special guest because he, lights up the room where he walks in. He's a person of Gen X, or is it Gen Z? I think it's Gen X, who has formed the correct combination of academic excellence, work-life balance, a perfect family man, a perfect father, as well as, keeps everything together very nicely. So we are very happy to welcome Dr. Rohan Palshetkar amongst us. He is professor at DY Patil, heads the unit of Bloom IVF. He is holding the post of chairperson Foxy Young Talent Promotion Committee, doing a wonderful job. He was the first joint secretary of AMOX, managing committee member of ISAR, MSR, as well as MOGS, with multiple publications and academic affiliations. He's also received a number of awards like Foxy Future Award, Amox B for Stree Puraskar, Foxy Corion, Shanti Yadav, Kumut Tamaskar, and late Praveen Mehta Award, Mog's Pramila Bhatia, Young Scientist, and Dr. S.C. Palib Awardee, Mog's Best Committee Member, Foxy Yuva Orator, ISAR Yuva Orator, and MSR Yuva Orator. Rohan, we're so happy to have you. So, are you there, Rohan? I spoke so many things for him, but I don't think, Purva, can you call Rohan? And
Yes, ma'am, I have called.
yeah. So he can join whenever he has time. So next I hand over the mic to my co-convener, Dr. Manisha Bajpai, renowned embryologist from Udaipur and a managing committee member of ISAR, to tell us how the program is going to look like.
Thank you so much, ma'am. May I have the program slide, please? A very good evening to all the path pavers. Just a minute, there's some glitch.
Yeah, we got the program slide here.
Just a minute. Just a very good evening to all the dignitaries and path pavers who have shaped the journey we walk today. We are truly delighted to have you all here. It is a real celebration of World IVF Day. Your blessings means a lot to us. On the eve of World IVF Day, it is a proud occasion to celebrate how far reproductive medicine has come. From the birth of first IVF baby to countless lives we now help to create. It's been a journey of science, compassion, persistence, and satisfaction. We feel happiest when we see our patients happy. But our struggle remains on for few patients. But the journey continues. But our dream remains unchanged, to achieve 100% success so that every couple longing for a child walk away with a smile. And in this quest, one of the most persistent challenge we face is recurrent implantation failure. a clinical enigma that demands precision, collaboration, and continued dialogue between lab and clinic. This evening, we have curated a focused and insightful scientific program that brings together some of the finest minds in the field. Let me walk you through it. We begin with a session by our own convener, by Dr. Monica Singh, a leading voice in reproductive medicine, who will speak on recurrent implantation failure, current guidelines, and patient-centered diagnostics. Her talk will set the stage for understanding how to approach RIF systematically and sensitively. This session will be chaired by Dr. Prerna Shinde, Dr. Shefali Jain, and Dr. Alka Galhot, and again, the very well-known names in the field. After that, we are honored to have Dr. Manish Bankar, sir, one of the most respected and experienced authorities in assisted reproduction. He'll be sharing his invaluable insights in the session titled From Protocols to Practice, Navigating Treatment Options in Recurrent Implantation Failure. His talk will reflect decades of clinical wisdom, practical approaches to this complex issue. Chairing this session are the Dr. N.C. Chimote sir, who is again a pioneer and a scientist in field of reproductive embryology, Dr. Sujata Agarwal ma'am, and Dr. Manjunath CS. This will be followed by a question answer session from 6:40 to 6:50 p.m., where we'll invite the audience to engage with our distinguished speakers one-to-one. From 6:50 to 8 p.m., we have an interactive and thought-provoking panel discussion on optimizing implantation outcomes, a dialogue between lab and clinic. This session will be co-moderated by Dr. Sulva Arora, who is known for her modest demeanor and a razor-sharp clinical insights, and yours truly. We also joined by the expert Dr. Chaitanya Shambekar sir, who is again one of the most renowned and experienced name in the field of reproductive medicine, a wonderful singer, surgeon, and a very nice human being, along with the stellar panel of clinicians and embryologists for a rich case-based exchange and tackling real-world challenges in implantation failure. And before we move ahead, it's my privilege to acknowledge the visionary conveners of this academic series. May I have the next slides, please? Dr. Monica Singh ma'am and Dr. Randhir Singh sir, a dynamic duo whose tireless commitment to the reproductive science and education continue to inspire us all. Dr. Monica Singh ma'am, may I have her slide? She is an accomplished reproductive medicine specialist and academic leader, has made remarkable contribution both clinically, academically, with multiple prestigious positions, including President-elect of Bhopal Obs-Gynae Society, National Executive Member of ISAR, Founder-President of ISO Parab Bhopal, Coordinator of National Proxy Infertility Committee, Joint Secretary MPIAG 24 to 27, and now Aparajita. She is reaching out to each and every village of India for women health. Her dedication to advancing women health is truly exceptional. Next, we are blessed to have another convener, Dr. Randhir Singh sir. Sir is an ISHRAE certified embryologist and gold medalist. He stands tall as one of the most respected embryology voice in country. With decades of experience, multiple leadership role, he is serving as a director and head embryology Bhopal Fertility and Endoscopy Surrogacy Center. He is remembered as an organizing chairperson of memorable 27th National ISAR Conference 2023 Bhopal. He is a managing committee member ISAR, member of MP PCPNDT board, member of MP ART and Surrogacy board, founder and executive member of Indian College of Reproductive Medicine, professor at Allen Medical College, and having over 50 international presentations, he continues to set benchmark in the field of ART and embryology. Their collective vision, deep-rooted values, and passion for perfection are what makes this series Perfection Fertisphere. Not just informative, but highly transformative. We thank them both for curating and leading this academic initiative with such a purpose and depth. We are truly blessed to have them with us. Thank you so much, ma'am. And now, stage is yours. Over to you.
You have been so overwhelming and profuse in your praise, Manisha. We don't deserve any of that.
No, ma'am. It is well deserved. That's what I feel.
So now, taking the program forward, I would like to introduce my very, very charming and beautiful co-conveners and coordinators. So they are the pillars on which the program is built. And even when I did the Perfection series part 1, we launched it with seniors. And this time we thought, let's have, a little younger crowd with us, because they are always fresh and enthused with fresh ideas. So we have Managing Committee member ISAR, Dr. Garima Sharma from Mumbai, and Dr. Manisha Bajpai, who's just spoken so sweetly, from Managing Committee member of ISAR from Udaipur. And can I have the CVs, please? Garima is well known as a very keen academician and a very hardworking ISAR member, who just recently also won the managing committee elections of MSR. She won the the ISAR elections. She became a managing committee member this year. And I was one of the judges when she got the Manish Banker Award. So she is truly a youth icon, and you can see the list of awards in her CV. She is, I think, from Punjab. She belongs to Amritsar, but she's, totally molded in the Mumbai mode, and is a very hardworking member of my team. Thank you, Garima. And now I would like to introduce Manisha. Garima will be joining us shortly. And
Dr. Monica, let me introduce, because clinician you have introduced, I'll introduce the embryologist.
sure.
Professor Manisha Bajpai, I think everybody knows her, but it's my duty to introduce her. She's the head of department of the Embryology Research and Pacific College at Udaipur. She's a managing committee member ISAR, executive committee member ACE, executive committee member ISAR Rajasthan, 23 peer-reviewed international publications, presented original research papers at ASHE many times, Aspire conference also, heading as a public that the first international publication from the country on infertility and microbiome, ISAR Shining Star Embryology Award she has got, ISAR Embryology Excellent Award 23, IFS Achiever Award 2023, then DST Young Women Scientist Award 21, ISAR Appreciation Award 2019, Research Fellowship from CSIR Council of Scientific Research, New Delhi, India, and overall, she is now presenting the embryology face to the Indian government, Indian private setup, because ISAR is the largest body, though ACE is considering the embryology part, but that body is of non-clinician. So they need some FOXY, ISAR or IFS. So Manisha is very right and enthusiastic, and I think that our flags, after what we have done, what we have seen is that from the ISAR started from the Parik sir, then we have come many people, Sadhna Desai ma'am, then Rishikesh Pai, Nandita, Rishkima Pai, then now Amit Patki sir, then soon Sunita madam will take. And I think in this gradual, as we have seen the young people in the embryology, at present we have Charudat Joshi, then we are going to have uh,
Keshav.
Keshav Malhotra, then Nishad, then young people are there. So I think here the embryology part, which now ART Act has come, because being a ART member at the state board, embryology part is still the clear, not very clear gray area. So you have to fight for that. So I think Dr. Monica, you can continue.
Thank you. Thank you so much. And Manisha is indeed a valued member of my team, my go-to person.
Thank you very much. I'm learning a lot in this process. You are the path pavers. You all are.
Thank you. And a word about my coordinators, who are equally important. So we take all the tiny decisions, but the major decisions are taken by coordinators as to what is going wrong, who is coming, who is not coming, who is available, who is not available. And this is done by these very hardworking. Dr. Purva Bhatkur is actually an assistant professor. She's soon going to be associate in the largest government medical college of the state, that is GMC Bhopal, also my alma mater. She is a keen academician, and she has a lot of teaching experience, and she is very active in all the gynecological topics, colposcopy training. She's been a Yuva orator, high-risk obstetrics, infertility, and she's recently become an ISAR member. So we expect her to start IVF in the government sector soon. Thank you, Purva, for always being there. And she was the one who, made that beautiful video, IVF video, for all of us to watch and enjoy. Thank you, Purva. We also have a coordinator, Dr. Shweta Agrawal, who is a very hardworking girl. She is not with us for some personal reasons, but she'll be joining us later. And we'll be joined by another coordinator next time, Dr. Payal Raghuvanshi. Hi, Payal, and welcome to the program. So now, without further delay, we hand over the mic to Purva Bhatkur. to take us to session number 1. Thank you.
Thank you so much, ma'am, for your kind words. Now, moving to our academic session, session 1, that is on recurrent implantation failure, current guidelines, and patient centered diagnostics. We have our own speaker, Dr. Monica Singh, ma'am. To chair the session, we have Dr. Shifali D. Jain, ma'am. Dr. Alka, ma'am, and Dr. Prerna, ma'am, will not be able to join us. Can I have the CV of Shifali, ma'am? Dr. Shifali Jain, ma'am, madam is presently
think
senior
Purva,
fertility.
sorry to interrupt, but then Purva, I think it's been long, so we can skip my CV, and straight away we go for the talk, the interesting talk by our own Monica Singh.
Shefali
So
ma'am.
we are all waiting for you to speak on the topic.
No, Shefali ma'am, I think
The topic of RIF, which is still unexplained and unidentified at so many occasions, and it is the most frustrating. It is a challenging situation for the doctors as well as frustrating for the patient, because at one point we have to balance the cost, other time you have to give results, and to make them understand that you have a chance still is something which is very important. And you're going to speak on the guidelines, I suppose. So I think I straightforward give it to you.
Thank you. Thank you for giving us those valuable minutes, Shefali ma'am. And everybody knows about her. She's the pioneer of the most, doing maximum cycles in Madhya Pradesh, setting a benchmark for all juniors to follow, giving state-of-art facilities. Dr. Shefali Jain and Dinesh Jain, sir, are names to reckon with in the whole of Central India. And now they have a second generation who is equally hardworking. We always look up to you, Shefali ma'am, for your, all guidance and support. And it's
Good wishes to for the beautiful series Perfection Fertisphere, and I congratulate each and every one of you.
Thank you, Shefali ma'am. It's an honor to have you as a chairperson. So, can I share my slides? If the studio can stop the slide share, please. So can you see the slides? Are the slides visible?
We can see them. We can see them.
Thank you. Thank you. So in the next, I know we are running late and we are all eagerly waiting for Dr. Manish Banker's talk. So I must tell before starting that recurrent implantation failure, I'll be taking the current guidelines and patient-centered diagnostics, which is actually a prelude to Dr. Manish Banker sir's talk. It is very difficult to speak anything before sir, because we know that is going to be the crux of today's academic scientific symposium. But it is necessary for us to explain what we are expecting in the actual lecture. Only when we understand the RIF, the models to actually diagnose RIF, and to know what threshold above which we call a patient as RIF, will we, actually understand Dr. Banker's lecture. We know that the journey of fertility treatment, right from the time we start investigating the patient to actually start management and achieve that pregnancy, is challenging not only for the patients, but also for clinicians, especially after having performed transfers of very good quality embryos and still not achieving that most, elusive result. And sadly, the etiopathogenesis of RIF, when the transfers fail 1 or 2 or 3 times, it is unknown. And because of this uncertainty of diagnosis and further management, healthcare professionals from all parts of the world are sometimes inclined to offer tests and treatments which are empirical and sometimes not evidence-based. But as astute clinicians of the year 2025 and beyond, with so many youngsters adopting ART as the field they want to practice, we have to have a means of individualizing treatment and learning the specific patient context of RIF. So this is how the websites of today are, looking like. This I took from one of the IVF centers website, where the patients are just explained RIF in this manner. There is an embryo transfer, and embryo falling out is RIF. So basically, what information are we giving to the patient? There was a time when most of us used to think about 2 decades back that a good quality embryo, no technical difficulty during embryo transfer, and a normal uterus will give us wonderful results. But now we know that fertilization and implantation window are not as simple as they seem. The seemingly simple process of fertilization, which we call as day zero, and the formation of the embryo in the distal part of the fallopian tube, and the form and the final precarious journey of that embryo right from the mid portion of the fallopian tube through all the convolutions of the fallopian tube, crossing that implantation window from day 2 to day 6, when it comes to be eccentrically implanted in one receptive part of the endometrium, is known as the implantation window. And by the time it rolls in and gets implanted, it has already formed an inner cell mass and an outer cell mass and come to be known a blastocyst. So there is many a slip between the cup and the lips. So similarly is the process of human blastocyst implantation. This blastocyst first has to hatch from the zona pellucida. Then the embryo has to first, oppose, then adhere, and then invade. So it is during the attachment stage of the embryo that there is a crosstalk between the embryo and the endometrium. This crosstalk induces upregulation of certain surface receptors. There is secretion of signaling molecules and hormones and cytokines, which directs the epithelium to absolutely melt away. That place the epithelial cells withdraw, and the trophoblast invades the endometrium, and the endometrium covers up that ball again. So what are the latest recommendations on RIF, and have we come to any guidelines? Yes, it was really, we were, discussing and basically trying to rack our brains on what to do with RIF patients when ASHRAE got together many clinicians, and they formed some good practice recommendations which are published in Human Reproduction 2023 and free for everyone to read and go through. I've also taken some, data from the Frontiers of Endocrinology, this journal published from China in January 2023, which is also a comprehensive summary right from etiology to treatment. Of course, the treatment part I will not be touching. And guidelines have divided the causative factors of RIF into the female factors and the male factors. So first, let us start with how ASHRAE has defined RIF. Now, ASHRAE Working Group on RIF categorically stated that RIF is a secondary phenomenon of ART and ART only, because it can be observed only in those patients who are undergoing IVF. That is why the following description of RIF has to be adopted. So every word of this definition is worth its weight in gold. RIF describes the scenario in which transfer of embryos considered to be viable has failed to result in a positive pregnancy test sufficiently often in a specific patient to warrant consideration of further investigation and or interventions. So the transfer of embryos has to be done minimum 2 times. Those embryos which you transfer have to be considered viable enough to survive. There is no positive pregnancy test in any attempt, and it has to be done sufficiently often in a specific patient till you reach that threshold to say that no, now she is not conceived, she has not conceived, she is a patient of RIF, and she requires further tests. So whenever we do a standard fertility workup in males and females in a couple, we have to go for medical history in both the partners. We have to do a thorough physical examination. In case of males, what is recommended is a simple semen analysis. They don't recommend any fancy tests like DNA fragmentation or FISH. But in females, you have to have a basic 2D ultrasound. A 3D is much better, where additional imaging is required. hysteroscopy has become like sort of now a partner of ultrasound for most of the practicing gynecists and infertility specialists. We also have to have an idea of ovulatory function. And I do believe that a simple menstrual calendar and the history taken from the woman and an occasional ultrasound, which you do here and there when the patient is, getting acclimatized to your clinic, will tell you about ovulation very well. Very rarely do we need laboratory testing for ovulation. And as and when you deem it necessary, you have to test for ovarian reserve by AMH, which is the most popular method. Now, what is actually the concept of cumulative chance of pregnancy, and what is the threshold above which you start treatment? The Among all ART patients, the chance of successful implantation differs in every specific patient. So you have to know what is a cumulative chance. Now, the cumulative chance, how they came to 60%, I'll be telling later. But if the cumulative chance of pregnancy is greater in a patient than an agreed threshold, but still no positive pregnancy test has been achieved, then action is indicated in the form of additional tests or treatment. Means there is a threshold of cumulative pregnancy rate in that patient of 60%. She has crossed that threshold and you have assessed that the chance of pregnancy is 65%. But still in that attempt, you don't get any positive pregnancy tests, so further action is indicated. But patients whose history indicates that the chance of conceiving thus far has not yet reached the threshold, you have assessed all the pros and cons and have found that the threshold she's reached is only 40% in that specific clinical context, then you should advise the couple to simply proceed forward to another ART cycle because they have not yet reached the threshold which they are entitled to. Sometimes in patients, the failure to conceive is, unusual. Everything is perfect. Still, you have some unusual circumstances wherein you stop treatment for some time and investigate the underlying contributory factors. So, two factors are essential for the individual approach for RIF. First, a model should be made and used to estimate the chance of implantation or pregnancy in a particular couple. And second, you have to determine the level at which the threshold to act is set. Threshold to act means threshold to either investigate for RIF and manage as per RIF. So the recommended threshold for cumulative predicted chance of implantation to identify RIF for the purpose of initiating further investigation is 60%. This has been formed after lots of recommendations, working group, data, questionnaire. So they had actually zeroed in on a threshold of 50%, 60%, 70%. Out of that, they found that when a couple have not had successful implantation using certain number of embryo transfers, the cumulative predicted chance of implantation associated with that number is 60%. And when the chance of implantation is greater than 60%, and the patient has still not become pregnant, they should be counseled for further investigation on the line of RIF. I know it's confusing, but we will see how this threshold of 60%, which has been delineated by ESHRE, can be integrated into clinical pathways. So this is an example to tell you all. This is a 36-year-old woman. She has got tubal factor, bilateral damaged tubes. She's been trying to conceive for 3 years. Primary infertility, never had IVF before, and she is using her own eggs. So after she has a good ovarian stimulation and pickup, we use the IVF Predict calculator. This is a model made by Nelson and Lawler. And the following calculations are made for this specific patient. This is an example only. Now, in this particular patient of this age, in the index IVF cycle, her chance of live birth per IVF attempt is 23.8. This is live birth per IVF attempt, according to the model, according to the tool. But every patient, you can't reach up to the live birth. So they altered it and achieved a formula wherein they will calculate her chance of pregnancy per IVF attempt. Now, chance of pregnancy per IVF attempt might not reach to the live birth, but it can be calculated by multiplying the live birth rate, which you have got 23.8%, into 1.16. So you get her chance of pregnancy, which is higher than the earlier figure. It is 27.6%. So now you've got this. Now, after two ETs, there's another formula which is given below, which is a little complicated, but you can understand when you read the whole text. Her chance of pregnancy is 47% if she does two embryo transfer attempts. Her chance of pregnancy is 62% after 3 ET, 72% after 4 ET, and 80% after 5 ET. So now what is the threshold? Threshold is 62%. So according to the threshold of RAF for more than 60%, if this woman has not become pregnant after 3 embryo transfers, we should intervene on lines of RIF. So this is again a difficult calculation, maybe only for research centers. So they came to the idea of clinic's pregnancy rate. So it is recognized that carrying out individual calculations per patient is not always feasible. So alternatively, we can use the clinic's data and clinic's pregnancy rate for specific patients groups. Here also they found a gross difference between embryos of uh, unknown euploidy and the euploid embryos. Where euploid embryos were used, you'll be surprised to see that PGTA was done on all the embryos and in all the age groups of the patients, whether less than 35, 35 to 40 or more than 40, they got almost equal pregnancy rate. So in these cases where euploid embryos are there, you have to and you don't get a pregnancy, you should intervene after 2 embryo transfers. But in those cases where embryos of unknown ploidy are there, in all the age groups, you can see you have to intervene according to the age group. The patient is less than 35. She doesn't become pregnant with best of embryo transfers. You intervene as RIF after 3 ETs. In 35 to 39, you intervene after 4 embryo transfers. In more than 40, you intervene after 6 embryo transfers. You have to give 6 embryo transfers to that patient of more than 40 with unknown euploidy status in order to call her RIF. So this is how the model works. So to make it simpler, we have done the basic fertility workup of that couple, and at least 2 good embryo transfers have failed to result in a pregnancy, and these embryo transfers should be done in a setup which is state of art, where the embryologists as well as the clinicians are experienced. You consider the cumulative chance of having achieved implantation. What was the cumulative chance of pregnancy over the course of 2 ETs which we have done? Or more ETs, but there should be at least 2 ETs. If the cumulative chance of implantation of pregnancy is less than 6%, this means the couple has not achieved that threshold. You proceed with another ART cycle. That is the left side column. If it is still not successful, you again go and consider the cumulative chance. If they have a successful pregnancy, well and good. But if the cumulative chance of implantation and pregnancy is already more than 60% with these 2 transfers, then RIF is suspected and you have to do RIF specific investigations and interventions. So after that, a little confusing sort of data which I gave, which I thought is very important in order to make a base of my talk, I will, just walk you through the diagnosis, the current evidence and controversies. Management, of course, will be by bankers, sir. So what do the guidelines state about lifestyle and vitamin D supplementation? These guidelines have come with very beautiful color coding. So wherever there is a recommendation which is to be adopted, it is a green. Wherever there is a recommendation which is to be considered, it is an orange. And wherever there are recommendations which are not to be recommended, means no recommendation, it is a red. So coming to the first, the lifestyle factors, very important to be investigated during fertility workup. And remember, patients' behaviors, both male and female, can change during the time that she is there in your clinic. So it is firmly recommended that whenever you review lifestyle, You again review them after a couple of weeks or months and optimize them whenever RIF is encountered. So in the course of the treatment, it is so stressful. The wife may have, started, just stopped exercise, and the husband must be maybe smoking more than 5 cigarettes. He must have gone up to 20 cigarettes. So you have to optimize all these lifestyle changes. Vitamin D is very fashionable nowadays, but there is insufficient data as of now to recommend the routine measurement of vitamin D levels or treating vitamin D deficiency, according to guidelines. Is the screening for genetic factors advised? Should you do karyotyping of the couple? So this is an orange, means can be considered, as well as a green, means yes. So despite low prevalence of genetic abnormalities, karyotyping can be considered in the couple to confirm the absence of any chromosomal abnormality, especially structural rearrangements. And if such chromosomal abnormality is detected, genetic counseling is warranted, and where relevant, PGT-A is recommended in that couple, which is a green. Anatomical investigations are very popular amongst our fraternity, and almost 85% of clinicians will take anatomical and gynecological investigations in account in diagnosing the cause of RIF. The popular tools with us being hysteroscopy, 3D ultrasound, 2D TVS, MRI diagnostic laparoscopy sometimes, sonohysteroscopy maybe less often, and HSG sometimes. So what is the role of 3D ultrasound? A young clinician might ask, should we do 3D ultrasound for every patient? So this is an orange. Orange means it can be considered. If 3D ultrasound has not been performed at the time of fertility workup earlier, it can be considered, and you should do it wherever RIF is suspected. What is the role of hysteroscopy? As we can see, hysteroscopy is very patient-friendly, clinician-friendly, and can be considered it's a green, especially when there is suspicion of a uterine anomaly visualized on TVS, and you want to go in and, assess the uterine cavity, probably, remove a polyp, a septum, or whatever abnormality you want to correct. It's very easy to do it. So it's a green. The role of endometrial receptivity assays and ERA, which used to be very fashionable about 5 years back, you can see it's an orange, means it can be considered because there is insufficient data to recommend routine use of these commercially available tests of endometrial receptivity, because whatever biopsy you take to assess the endometrium for the window of implantation as pre-receptive, receptive, and post-receptive, specific aspects of endometrial function cannot be tested by ERA. But in some cases, you can do it. But studies over a long time have told us that there is no actually difference in the results when you do an ERA and when you don't do it. Assessment and treatment of chronic endometritis. Now, this is a condition which is again in orange. So again, there is lack of standardization, but most of us clinicians would like to investigate a patient for chronic endometritis, do a good ultrasound, try to make a 3D, see the junctional zone, take a history, and do the counts and the antibiotic treatment. There is no harm in doing that, but of course we require more standardization. And if chronic endometritis is diagnosed, treatment with antibiotics can be considered. Should you reassess endometrial thickness and your protocols after the patient has got RIF? That's a green. Recommend a reassessment of endometrial thickness is definitely recommended. You should review your estradiol treatment regime, whether she is responding to the vaginal route or whatever route you have taken. Does she require dermal application or does she require the injectable route? If the endometrium is noted to remain persistently thin, hysteroscopy is advised in order to rule out adhesions or Asherman syndrome and correct it. Microbiome is a very, very fashionable word nowadays. And should you profile the microbiome? Now, the whole microbiome of the body, about 10% of it is residing in the uterus and the vagina. And the predominant species is lactobacillus, and very many studies have found that lactobacillus in the endometrium is deficient at the time in those cases where the embryo doesn't implant. But having said that, there is so much of variation in the different parts of the menstrual cycle in the microbiome, flora, and population that routine profiling of uterine and vaginal microbiome is not recommended by ESHRE as of now. Metabolic and endocrinological factors are definitely important. And when a survey was done, it was found that 82% of clinicians would rely on metabolic and endocrinological factors testing, most of their focus being on thyroid function, prolactin levels, diabetes, PCO. But still, out of all these, it is mainly thyroid function, which is well established in clinical practice to be associated with the RIF, and that's in orange, but I think a green for India. Assessment of thyroid function can be considered and should be done. Progesterone levels estimation is again something, should we do it or should we not do it? It's an orange, can be considered. So there are two types of progesterone levels which are important as far as RIF is concerned. First, the assessment of the late follicular levels of progesterone, wherein at the time of trigger, if the progesterone levels are high, you might have embryo-endometrium dialogue asynchrony. And second level, which is important, is the mid-luteal progesterone levels, which, if deficient, have to be supplemented by exogenous progesterone in order to have a good implantation and ongoing pregnancy rates. Coming to natural killer cells and uterine T lymphocyte assessment, again, not very regularly and routinely done tests and do not actually have any difference in the results in studies which were done, multicentric center studies and randomized controlled trials. The data is not sufficient. So ESHRE has not recommended either peripheral or uterine natural killer cells testing. And uterine natural killer cells are not cytotoxic like peripheral natural killer cells. Similarly, uterine T lymphocytes assessment is not recommended in order to improve your results of RIF. Similarly, with blood cytokine levels and HLA-C compatibility, again, research work can be done, but assessment of blood cytokine levels and HLA-C compatibility is not recommended to improve your RIF results. Now, a very important part of RAF is antiphospholipid antibody syndrome and antibodies, the acquired thrombophilias. So this is a green. And it is a green because assessment of AP and APS is recommended in RIF women, especially who have additional risk factors for thrombophilia in the form of a family history or a previous episode of venous or arterial thrombosis or an obstetric history. And it can also be considered in those women without such risk factors if you feel it is necessary. So that's a green. Now, what about assessment of embryo mitochondrial DNA content? There are so many embryologists, gracing our webinar, and we know that the mitochondrial DNA content of the embryo is strongly correlated with the viability of that embryo and its implantation potential. But the data and the number of patients who have been assessed with this technology are so few, and it is so expensive and a very tedious process to do that evaluation for RIF is not yet recommended, requires a couple of years more till it becomes commonly known to all of us. Similarly, sperm DNA fragmentation, now we are getting so many pharma companies and people coming to us with kits. Sperm fish has become very in vogue nowadays. But definitely for RIF, whether you do a sperm fish or sperm DNA fragmentation, it is as such not recommended by ESHRE to give you any improvement in result. Endometrial scratch or intentional endometrial injury used to be again in vogue about 15 years back, but now it has come into disrepute. Any sort of intentional endometrial injury, it's a red and it's not recommended. Lifestyle factors we've already spoken about, and now coming to very, very controversial GCSF, that is granulocyte colony stimulating factor, intravenous intralipid infusion, which is actually a parenteral therapy for nutrition, and intravenous immunoglobulins IVIG. So GCSF, we have been using it, and I admit I still use it intrauterine for endometrial thickness, subcutaneous, and it's not recommended. The intrauterine part of GCSF is said to improve the endometrial thickness by the vascular action. Subcutaneous, the administration of GCSF is thought to give an immunomodulatory effect. Intravenous intralipid infusion is also being used for immunomodulation. Intravenous immunoglobulins is also to combat the body's autoantibodies to the embryo. But all said and done, these are not recommended. In fact, there are so many serious patients all over the world who require intravenous immunoglobulins, which are taken from human beings. So it is ethically also not correct to use IVIG empirically for RIF patients when there are so many patients, serious patients who actually require it and are not getting it. So coming to intrauterine peripheral blood mononuclear cells, intrauterine platelet-rich plasma, and intrauterine human chorionic gonadotropin. Again, none of them, though I can speak about each of them because they are not recommended, let us not waste time. And just one word about pre-treatment with GnRH agonist and aromatase inhibitors. This pre-treatment used to be done in those cases where you're suspecting some subclinical type of endometriosis. So sometimes you put a scope, you take history, still you're not able to diagnose endometriosis. So this pre-treatment might help the RIF patients, but ESHRE has given it a red. And again, LMWH, unless there is an indication with antiphospholipid antibodies or thrombophilia, it's not recommended by ESHRE to increase the chance of pregnancy. What about pre-implantation genetic testing? It's an orange. It's recommended wherever you feel it is necessary. PGTA, as I told you in the table earlier, the chances of implantation increase dramatically when you have got euploid blastocysts or euploid embryos. So this is a technology which can, help the RIF patients. What about assisted hatching? A lot of the embryologists used to, break the zona pellucida partial or complete hatching in order to assist the blastocysts in implantation. But it has been, especially in the elderly women and in frozen embryo transfers, but it's not recommended by ESHRE. Coming to blastocyst transfer, it is an orange. It can be considered in RIF cases because the blastocyst transfer helps in three ways. Number one, the blastocyst, by the time the embryo reaches the blastocyst, the chances of aneuploidy are very less. Number two, you achieve a certain level of embryo endometrium synchrony. And number three, at the time of blastocyst transfer, the uterine contractions are also minimum. So that is why blastocyst stage embryo transfer can be considered. Coming to the end of my talk, I would again walk you through the green recommendations, which are a yes, orange, which are can be considered, and the ones which are not to be recommended, I'll not be reading. So we recommend alteration of lifestyle factors. We recommend you assess endometrial thickness. You correct the intrauterine anomalies. You assess for AP and APS in case there are risk factors. You can consider karyotyping. You have to consider 3D ultrasound where necessary, hysteroscopy wherever it is needed, endometrial function testing only when it is indicated and you have good facilities, chronic endometritis testing and subsequent antibiotics, assessment of thyroid function, yes, and progesterone levels as you feel clinically necessary. And interventions, of course, will be taking. So there is no one size fits all model for supportive care in patients with RIF. We have to recognize this woman or couple as an individual, provide ample time for questions, information, repeat, discuss, especially because they are distressed and anxious. Listen to facts and feelings of this couple, show respect for patient couple and their wishes, choices, use clear, sensitive language, explain terminology, avoid scientific jargon, avoid insensitive terms, and mirror the patient's preferred choices. Be honest about all the processes you suggest, likely outcomes and prognosis. Avoid false reassurances. And sometimes they have to be reassured when the threshold, they are far away from the threshold. You have to simply reassure the individual on the likelihood of implantation in the next cycle, that simply continuing with ART treatment may be a good option, because there are studies which have shown that half the patients with RIF will achieve a live birth with ART if they just continue treatment with a good center within 5 years. And sometimes a multi-cycle approach is also necessary. We sometimes criticize the corporate centers that they are giving, options of so many cycles, a package approach, but actually it is beneficial because in a multi-cycle approach, the patient doesn't expect pregnancy in the first cycle. So if there is cycle failure, the couple is already coping with it and they are ready to start the next and the third cycle. Always be kind, show concern, empathy, and compassion. And therefore, we have to reconsider, according to the ESHRE working group, reconsideration of RIF from being a medical condition with fixed diagnostic criteria to a clinical condition which is secondary phenomenon of ART only. It can arise at different moments in different patients and requires a great degree of empathy and pragmatism to manage it well. It's one of the top 10 research priorities in medically assisted reproduction, and we should have a rationale behind every treatment we propose. And these are the research topics which have to be studied in the next decade if we want to go ahead with progressing. I thank ISAR for this opportunity and invite everyone to become member of ISAR. We have a special discount for ISAR Life membership from 18 July to 1st of August. You can visit our website for the details. Thank you very much for a patient hearing.
I think, Monica, you were fabulous as usual. And you brought out such good points of discussion. And I think as far as the guidelines are concerned, I think we have to appreciate so much of work is being done, and the guidelines have clarified so many gray zones, especially, individualizing the definition, because this was always a confusion whether 2 embryos, 3 embryos. So they have very clearly said that sufficiently often, the embryo transfer, and that too depends upon the prognosis of the patient, the age of the patient is considered, the prognosis in a particular case. So the guidelines, I think, are very individualized. As far as the diagnostic things are concerned, I mean, everything has been pointed out so well and you've tried to explain. But my discussion is like, this is a guideline. But I want to know from you, Monica, what should be the practical thing? Like, if a patient of RIF comes, so do you perform all the tests in one patient, or do you specify it? Or what exactly should be done? That should be the take home message, because the guideline specifies so many things. So what should be done in a particular case as far as from your end is concerned? That is number one. Secondly, the papers are not brought by the patient, because what kind of embryo transfer technique? Or do you consider ovarian stimulation protocol also when you deal with a case of recurrent implantation failure? Then what about the embryo? How much to trust a particular center? So many things are there. So I want a little practical aspect from the guidelines, how one should go ahead in a case of RIF when the patient comes to you.
Thank you for those very good and practical questions, Shefali ma'am, and thank you for chairing the session. I think many of these cobwebs will be cleared by Dr. Manish Bankar's talk. But what I feel is that sometimes we do not achieve that level to be labeling a patient as RIF, because by the time she finishes 2 or 3 cycles with a particular center, the patient picks up her papers and goes to another center. So in India, I think a lot of data is lost because we have not given the multi-cycle approach to the patient. And the multi-cycle approach is not given to the patient because of financial reasons also. Because sometimes the patient feels that she is not able to cope with the enormous financial burden. And secondly, we have to go with the greens, madam. The ESHRE has made it so simple. It has done away with all the controversial tests and techniques. And now we'll know the treatment strategies from Sir, who holds years of experience. So the greens we have to do. We have to test for thyroid. We have to rule out thrombophilias. We have to, use heparin where required. We have to do a hysteroscopy. We have to do a 3D ultrasound. And we have to give sufficient number of cycles to the patient with good quality embryos. That is the way forward. We have to motivate, and we have to just talk to the patient till they are convinced that we want it as badly as they do.
Absolutely correct. So I think we have to focus more on the basics and tell them, and I think educate them for more advanced diagnostic things which are available and the treatments which are available, which obviously Manish will be talking.
Thank you, ma'am. Thank you. So, hello Chaitanya, how are you? Purva, I think we can go to session number 1. Thank you very much, Shefali ma'am.
Thank you so much. Thank you very much for inviting.
Thank you.
Thank you, ma'am, for the wonderful talk. Now moving to our second session. Mr. Anmol, can we have the slide? So moving to our second session, from protocols to practice, navigating treatment options in recurrent implantation failure, we invite speaker Dr. Manish Bankar sir. To chair the session, we have Dr. N.C. Chimote sir and Dr. Sujata Agarwal madam. And Dr. Manjunath sir has not joined yet. Next slide. Dr. N.C. Chimote sir. Sir is the Managing Director and founder of Vasundhara Fertility Center. He has a very sharp vision and an analytical mind with lot of academic and paper published of more than 75 original research work. We welcome you, sir, to chair the session. Next, we have Dr. Sujata Agarwal, madam. Madam is presently Secretary Delhi Chapter ISAR. She is being editor of Delhi Gynecologist Forum, South Zone Coordinator, Menopause Society of Delhi, Executive Member of Adolescent Health, AOGD. We welcome you, ma'am, to chair the session. Now I hand over the session to us, the chairperson, to introduce our speaker, Dr. Manish Bankar. Over to the chairpersons.
Hi, Manish.
Good evening. Good evening.
Good evening.
Can we have the CV?
Can we have the CV, please?
Anmol?
Yeah. Of course, I mean, Manish is a very old friend of mine since 1999. So I know him very well. He's a tremendous academician. He is also a very adroit clinician, I can say. And he has got so many awards and so many things to his name that it is difficult to count all those things in this particular thing. And Dr. Manish Bankar is a very well household name, you can say, for all clinicians all over India in IVF field. So I need not take much of your time, Manish. Will you please start your lecture, please?
Please. Thank you very much for the invitation and the kind introduction. Dr. Monica has taken you through the basics about the definition of recurrent implantation failure and the ASHRAE guidelines. I will focus more on specific treatments, but there could be a few overlaps, and just excuse me for this. So, RIF is a fairly complex issue, right from its definition to its possible etiology and its management. And we begin with, when do you classify a patient as having embryo transfer as recurrent implantation failure based on transfers or embryos? And there are many, many definitions which have been proposed as to how many cycles and what age, what quality of embryos, day 3 versus day 5 embryos, so on and so forth. But we now are sort of evolving towards a consensus, and there has been a lot of a demand or a request for redefining the way we look at our patients with recurrent implantation failure. Because by and large, the proposed definitions were based on clinical judgment and also affected by patients' demands. And a lot of this was not based on robust scientific considerations. And hence, there is a tendency to both overdiagnose and hence overtreat this condition. So the new definition that one should be looking for should be based on the fundamental fact that it should start becoming a concern after several embryos have failed to reach a live birth. That is fundamental. But it should mark the point where additional investigations or a change in treatment plan would improve the outcomes. So this should be the crux, I feel, as to when you shift from standard treatment to classify as RIF, when you feel that any additional investigation or treatment is going to change your treatment plan, because otherwise it doesn't make sense wasting time and money and effort behind this. So where does this evidence come from? And I'll show you two papers which have tried to approach this. Now, this is one paper which is looking at the implantation rates in patients in their first, second, and third euploid embryo transfer. So this is post-PGTA. But forget about PGTA and non-PGTA. What this tells is that the pregnancy rates and the implantation rates are practically the same after the first, second, and third embryo transfers. And after 3 embryo transfers, one would achieve a sustained implantation rate of around 95.5%, which means only 4.5% of patients would be left after 3 euploid embryo transfers. So the largest basket that we are looking at is only 4.5% of the patients. And this is what most of the people have started to agree, that one, true RIF is not very common. It is less than 5% of couples. And for the rest, reassurance and continuing the conventional therapy are all that is needed. And it would seem reasonable that you assign this diagnosis to a patient only after 3 euploid embryo transfers, or an equivalent number of untested embryos adjusted by her age have failed to achieve a pregnancy. But now we have evidence even beyond that, because there are some thoughts that does it even exist? And what this group has done is it has looked at the pregnancy outcomes after the conventional 3 euploid embryo transfers have failed. So they have looked at pregnancy rates in the 4th and the 5th embryo transfer without any investigation. So this is a large study, 125,000 patients, 65,000 euploid blastocyst transfer. What they showed that after the 3rd transfer, if you look at the pregnancy rates in the 4th and the 5th, they have not done anything, no special investigations, no treatment, just continued with embryo transfer. And they found that the 4th euploid transfer achieved a live birth rate of 40%, and the 5th euploid had an equal pregnancy rate of 50%. So even if you go up to 5 euploid embryo transfers without investigating for RIF or doing any other subsequent treatment, nearly 98% of the patients would become pregnant. So this then brings down the possible incidence of RIF at a minuscule 2%. So again, the question is this a serious enough problem that warrants so much investigations and so much discussion and so much treatment? Having said that, I acknowledge and I understand this is a very perplexing problem when we're sitting across the table from a patient, and when 2, 3, 4 embryo transfers fail, it is very difficult to just sit back and tell them that no, everything is fine, just keep on doing what you have been doing. So by and large, most studies today are mentioning that it should be 3 embryo transfers, but there is evidence that the 4th and 5th are also not so bad. So the current consensus is to define it as failure of 3 euploid blastocyst transfer or an equivalent number of unscreened embryos based on the patient's age. In addition, whenever you are looking at this, we should always try to rule out factors which could have contributed to this, and this could have led to a reduction in implantation potential, because many a times when you start the treatment, you have not been able to identify, or some factors start developing only when you are treating the patient. Commonest things are like a small polyp developing during stimulation. So you should try to rule out contributing factors when you are treating such patients. This is the whole basket of possible reasons, from your stimulation to the endometrium, to the transfer, to the embryo, thrombophilias, hydrosalpinx, and so on and so forth. But let me first start with the contribution of the male. What is the contribution of the male and the sperm in recurrent pregnancy loss? This applies to RPL, but I think it is equally true for RIF. Now, first is that such patients are more likely to have a high sperm DNA fragmentation. Second, they are more likely to have a sex chromosome aneuploidy or a aneuploidy in 13, 18, or 21, and hence a possible role of recurrent of pre-implantation genetic testing. At the same time, there are also publications which suggest that sperm DNA fragmentation does not predict neither RIF nor even a pregnancy rate. And this is also a large study, nearly 400 couples who have been assessed with their DNA fragmentation and no difference in the pregnancy outcomes or incidence of recurrent implantation failure. What about the father's age then? Because paternal age is also thought to be contributing to this. And this is in nearly 1,500 men with normal parameters and with abnormal parameters. And what they found was that the aneuploidy rates of paternal origin was the same in men who have a normal semen concentration versus abnormal semen parameters. And they also found that the aneuploidy rates are similar in men aged less than 50 years and those aged above 50 years. So the issue of male is extremely doubtful. And if you look at the guidelines from the Canadian Fertility Society, it recommends that sperm DFI testing should not be offered in RIF because the amount of evidence is very weak, the strength is weak, the quality of evidence is low. So we should not start looking at sperm DNA fragmentations. This then brings to the major part of the discussion, and that is the female partner. What about controlled ovarian stimulation? This is a very interesting publication which looks at the oocyte cohort effect. So there is a thought that isolated cohorts may not be so good. So when you're looking at ovarian stimulation, maybe the cohort in one particular cycle could not be so good. The second cohort might be better. And we have seen how women respond differently in different stimulation cycles. In spite of having the same protocol, the responses are vastly different. So there is a possibility or a thought that we should never define RIF on the basis of all embryos arising from a single cohort. Second, very important and an equal important aspect is that the lab performance in that particular cycle could have been suboptimal. And if you do another cycle, this could be genuine mistakes. This is not mentioning that the labs are bad. You could have minor errors everywhere. But if you have another cohort, maybe the lab performance would have been better and you could have better quality of embryos. So both this point to the fact that one isolated cycle or embryos arising from one isolated cycle should never be considered because the next cohort or the next lab performance could be better and you could have a completely different outcome. What about the issue of premature luteinization then? So what is this? Now, premature luteinization is a condition where the progesterone rises not because of the escape from LH surge. This happens in patients who have been given the LH to suppress the occurrence of the premature surge. But when the patient has supraphysiological levels of estrogen and progesterone, there is a rise in progesterone also, and this happens more common in recombinant FSH only stimulations, and the progesterone tries to go up to above 0.5 or 1 nanogram per ml. Once this happens, the endometrium starts getting advanced, and there will be endometrium blastosis asynchrony. And this high progesterone, which does not affect oocyte quality or fertilization, but will affect the implantation potential and In such patients, you should freeze the embryos and defer your transfer to the subsequent frozen embryo transfer cycle. Everyone knows about the role of hydrosalpinges, that women with hydrosalpinges have a significantly lower chance of pregnancy versus women without hydrosalpinges. It is seen in both fresh cycles and frozen cycles. The rates are different. When it is bilateral, the fall is more significant versus unilateral hydrosalpinges. Larger hydrosalpinges have a poorer outcome versus a smaller hydrosalpinges. So all this is a fact. And based on this, ASRM has come out with guidelines that if the patient has ultrasound visible hydrosalpinges, you must counsel the patient about the need for salpingectomy, because for every 6 women with hydrosalpinges, you could achieve 1 more ongoing pregnancy if the damaged tube has been removed. And this is very, very significant. But there is a new problem which we are now seeing, and that is the occurrence of isthmoseals. Many times when you scan these patients post a cesarean section, you find collection of fluid either restricted to the previous cesarean scar or sometimes in the entire endometrium. And such isthmoseals will prevent the implantation. There is now evidence again that isthmoseals are common if the cesarean incision was very low. It was a low cervical incision. It is commoner following the single layer closure methods that is now being followed versus the 2-layer measure method which we used to follow in our school days. And if the other measures like non-closure of the peritoneum above the uterus is also thought to be a contributing factor. So maybe the way we are doing cesareans has led to the increasing incidence of isthmosele, and we should rethink these methods in terms of its impact on patients' future fertility. And hysteroscopic isthmoplasty, if you are able to shave off this, or if it is not possible, you do a laparoscopy, you dissect the bladder and you close the isthmosele, the live birth rates and the pregnancy rates increase significantly in such women with isthmosele. So this is something which you should correct if the patient is having repeated IVF failures. What about the endometrium then? This is where the embryo is going to implant. What you want is such a typical triple line endometrium. The thickness of the endometrium is again a matter of controversy. Most publications suggest that an endometrium of less than 7 millimeters suggests impaired implantation, but we know that pregnancies have also happened with thicknesses as low as 4 millimeters. The ectopic pregnancies occur in the tube where the tubal epithelium endometrium thickness would be extremely low. We have ourselves shown that with every millimeter increase in endometrial thickness beyond 7 millimeters, there is an increase in the live birth rate. So we should aim for a thicker endometrium with whatever means that are with our disposal. Should we then do a routine hysteroscopy in our patients? So this is the INSIGHT study, multicentric study, which concludes that routine hysteroscopy does not improve the live birth rates in an infertile woman who has normal transvaginal ultrasound of the uterine cavity before the first IVF treatment. So routinely, it does not help. But what about in patients who have recurrent implantation failure? Again, the TROPHY trial, a multicentric RCT, women below the age of 38 years, 2 to 4 failed IVF cycle. Again, this concludes that outpatient hysteroscopy in women who have a normal ultrasound and a history of IVF failures, this hysteroscopy does not improve the live birth rate. What about the endometrium from its genetic perspective? We predominantly focus on the endometrial thickness, the endometrial echogenicity. But what about the endometrial receptivity? So the endometrial receptivity analysis is a test which looks at nearly 250 genes which are involved in the process of implantation. For an endometrium to be receptive, some of these genes get upregulated, some of these genes are downregulated. And based on this pattern of up and down regulation, you could classify whether the endometrium is receptive, it means it is okay, or is it pre-receptive, meaning it has not yet reached the receptivity stage and needs an extra day or so, or it is post-receptive. That means that the receptivity window is already closed and the transfer should have been done one day earlier. But there has been a lot of controversy as to the utility of this test. And this systematic review and meta-analysis tells that in patients with good prognosis, endometrial receptivity does not help. So this is the first learning point regarding ERA, that it is not a test for everyone. It does not help patients who have a good prognosis. But it significantly increases the chances of pregnancy in non-receptive patients having recurrent implantation failure of endometrial origin. So it does not help everyone, but if the non-receptivity is through the endometrium, then it should be of benefit. Another systematic review and meta-analysis again suggests that doing a personalized embryo transfer helps these patients who have recurrent implantation failure. And this is exactly what we have studied nearly 6 years back. 250 patients with history of 4 previous failed embryo transfers. So the first thing that we found was that the endometrium is non-receptive in only 16%, 18 to 19% of these patients. So if you look at all patients that you treat, patients classifying as RIF would be 10%, and of this, only 20%. So the overall incidence of patients is what we are defining today, not more than 2 to 3%. But in these patients, if you find that the endometrium is non-receptive and you do a personalized embryo transfer, you are able to achieve very good cumulative live birth rates, whether it is with self oocytes or with donor oocytes. So this is a test which is not for everyone. And this is exactly what this SWOT analysis tells you, that it has a strength because you can personalize the window of implantation for a physiological plausibility. But the weakness is that there are commercial interests which are leading to some bias, and it will not help every patient. It also mentions that the test has to be validated before it is marketed. So you should be asking for evidence that if you're doing a transfer in a non-receptive endometrium, what are the implantation rates and the live birth rates that have been published? Only then is that particular test thought to be validated. So an important test, but for a small percentage of patients, it is not for everyone. So this non-receptive endometrium might be just one of the multiple causes for RIF, and doing a personalized embryo transfer will help such selected patients having RIF. What about the role of probiotics? Now, it is believed that the endometrium has to be lactobacillus dominant, and if it is not so, then you supplement the patient with lactobacilli and it will help in improving the pregnancy outcomes. Similarly, if you have evidence of chronic endometritis, sometimes what you do find is when you do a hysteroscopy, you have a highly vascular endometrium with a lot of blood punctate, and you can give them long-term antibiotics in the form of doxycycline, and that also does help in improving the pregnancy outcomes. So this is the current perspective, that if you are suspecting chronic endometritis, you should treat the patient with antibiotic. Or if you are suspecting altered endometrial microbiota, you can supplement with lactobacillus. But how do you identify the patient? What do you give? Oral versus vaginal? These are still unanswered questions. What about these other interventions which are being tried. Endometrial scratching. Now, this was the first publication on scratching way back in 2003. And what this publication mentioned that local injury doubles the incidence of successful pregnancy. Now, imagine any intervention which can double the pregnancy rate. I don't think of any other intervention in IVF, which even in a small study has shown this. But this started the whole gamut that everyone started to rush into this. But the moment we had RCTs into this, they have conclusively proven that it does not help improve the pregnancy rate because the procedures are not standardized. When do we do? How do we do it? This is all completely undecided. So the randomized control trials, looking at this, large number of publications have confirmed, but it took us 15 years to confirm that endometrial scratching does not help in improving IVF outcomes. Similar thing with GCSF. The first publication came from Dr. Gleischer's group. They did endometrial perfusion in 4 patients, and they found that all 4 patients became pregnant. Look at this. This is a publication from Dr. Gleischer, and it came in 2011. Based on this, the same author did a randomized trial. Now it is 140 patients, 70 patients in each arm. And what he himself concluded 3 years later is that GCSF does not benefit. So the person who pioneered the procedure has himself published that the moment you start moving into the era of RCTs, the procedures do not benefit. Similarly, about PRP, we have very little evidence and it does not allow us to draw definite conclusion about its effectiveness. Then comes another black box in the various thrombophilias. Now, what are these thrombophilias? You have 2 types. One is autoimmunity. These are the lupus anticoagulants and the anticardiolipin antibodies. What they do is they lead to an autoimmune response. It is targeted against the platelets and the vascular endothelium. And based on this, and the other way this works is the cells. These are a type of lymphocytes which are circulating in the peripheral blood, and they have been given this name because they have the ability to kill some leukemic cell lines in vitro. Understand this. They've been called killer cells because they could kill leukemic cell lines. But retrospectively, it is this misnomer because they're extremely poor at killing the same lines we now know. But this misnomer has stuck that there are something called killer cell lines. And this have been a driver of the myth that these cells can even kill the embryos and can lead to reproductive failure. But these emotive claims do not have any supporting evidence because first of all, killer cells never come in contact with the embryo at all. They only come into contact with the trophoblast. Secondly, they cannot kill trophoblasts unless they are exposed to very high doses of interleukin interleukin 2. And this interleukin 2 is absent in a pregnant uterus. So the whole theory that NK cells can actually kill this is without any evidence. And hence, the RCOG came out with this advisory that measurement of peripheral blood NK cells or any other surrogate marker is no better than tossing a coin in the air. So keeping this in mind, again, a systematic review and meta-analysis, the evidence is extremely sparse and is of very limited use, and it should not be put into routine clinical practice. Then what about all these other treatments which are thought to improve implantation? Steroids, aspirins, heparins, so on and so forth. And I'll have one slide on each of this. Larger studies, only not individual studies. So Cochrane Review 2012, no clear evidence that peri-implantation steroids have any benefit. Aspirin, again, Cochrane Review, 13 trials, no evidence that it improves the outcome. Heparin in patients with IVF or with RIF, again, no evidence that it improves the pregnancy outcomes. Just give me a minute. Just so again, the role of heparin. This Cochrane review concludes that these particular findings do not justify the use of heparin except in well-conducted trials. Same for the use of intravenous immunoglobulins. It does not improve pregnancy rates in couples with repeated unexplained IVF failures. So if you look at the evidence for all of this, again, intravenous intralipid, not beneficial in patients with recurrent miscarriages or with recurrent IVF failure. Same thing with paternal leukocyte immunization, the so-called LIT therapy in patients with repeated IVF failures. Again, it was not shown to be of any benefit. So if you look at all the RCTs, forget the case reports or small series, the moment you move into RCTs, none of these procedures have been of any help. And this led to this very evocative paper from the Cochrane Library that for immunomodulation treatments, where is the evidence? Where is the evidence on which you are moving into this? Because all adjuvants are based on some theory without proper validation, without any possible long-term side effects. This comes at an extra cost to the patient, and there is lack of consistent results. And hence, till we have validated long-term RCTs, which suggest that this have a definite benefit, I think we should not start to modulate the immune system. And this is what the ESHRE guideline is, that for NK cell, U20 cells, HLA, APS, none of this is recommended in patients having recurrent implantation failure. So then this brings us to the last and, from my perspective, possibly the most important variable, and that is the embryo. Now, there are two ways on which you can assess the embryo. One is the morphology. And the first thing you should do is move to a blastocyst transfer, because this will help in selecting a more viable embryo. Because embryos which are genetically defective typically would not reach the stage of a blastocyst. And it will also avoid the inheritance of the abnormal paternal genome, because this is what I showed earlier, that in PGT reports, which are exclusively done on a blastocyst, the abnormalities of paternal origin are the same in young men, old men, normal semen parameters, abnormal semen parameters. So possibly the blastocyst stage development takes care of this. And this is something which, again, the Cochrane shows that the pregnancy was much better in the blastocyst stage transfer, primarily because of the lower risk of embryo aneuploidy, and also because there is a better synchrony between the embryo and the endometrium. But what about the genetics of the embryo? Now, aneuploid embryos obviously will either not implant, or if they implant, they will lead to a miscarriage or an abnormal pregnancy. So it makes logical sense that if you are able to test the embryos and you are able to weed out the aneuploid embryos and transfer only the euploid embryos, you would have better reproductive outcome. But where is the evidence? And the question that you should be asking is that, is it necessary for young patients with RIF to undergo this testing, or is it restricted only to older patients? And this is exactly what this study suggests, that it improves clinical pregnancy rate in patients who are above the age of 38 years. But there is another publication which looks at both young and old, again, 1,400 patients. And this study suggests that in both under 35 and over 35, there is an improvement in the live birth rates following pre-implantation genetic testing. However, the current consensus is that for unselected population, this does not help. But if you look at specific selected populations, testing of the embryo would help. Another aspect which is not very often tested is that nearly 3 to 5% of couples with recurrent implantation failure have a structural aberration. And if you are able to identify these structural aberrations, either in the form of a reciprocal translocation or a Robertsonian translocation, these are not necessarily associated with recurrent pregnancy loss. You could also find this in recurrent implantation failure. And then if you offer PGT-SR, you will be able to transfer only balanced embryos and achieve the desired pregnancy outcomes. But then this brings us to this million-dollar question that even after doing all this, why does a euploid blastocyst fail to implant? I mean, you have tested the embryo, it is a euploid embryo. Why wouldn't all of these euploid embryos transfer? And let us look at some interesting revelations from this study. First is the effect of maternal age independent of anything. So what this study has shown that in women who are 38 years at the age of retrieval have a lower birth rate even after euploid embryo transfers. So in elder women, even if the embryo is euploid, whether they do a single embryo transfer or a double embryo transfer, their miscarriage rates are similar, but their live birth rates are lower. So in older women, even a euploid embryo possibly has some other factors where it does not lead them to implant. So there is a possibility that there is a detrimental effect of maternal age, which cannot be offset simply by doing a PGTA, because the incidence of pregnancy rates following a euploid embryo transfer is lower in a woman who is 38 and above versus a woman who is under 35. The same thing has been found that in obese women with BMI above 30, they have a lower live birth rates following euploid embryo transfer. So again, obesity per se is also an independent risk factor, even following transfer of euploid embryos. And what about the paternal aneuploidies coming from the father? Again, at the blastocyst stage, again, as I mentioned, moving to a blastocyst weeds out the paternal influence. These aneuploidies are less than 10%, and neither the paternal age nor the severity of male factor influences the live birth rate. So it is the mother's age. If you're doing a PGTA, you are able to eliminate the side effects of the paternal age, but not of the maternal age. And the last thing, and again, a very important, is the influence of your lab or the laboratory parameters. And you must have robust QA/QC methods within your lab so that you are able to consistently produce good quality embryos. So then this brings us to the end, and I have two questions to ask. Where do we stand today then? And what do we do for these patients? Let me share you some very interesting insights and papers. Now, this is a statement from Hans Evers, the late editor of Human Reproduction. What he mentions is that recurrent implantation failure is a made-up disease. It is refined into another made-up disease. It is treated by unproven treatment. And when you think that we would have scraped to the bottom of the barrel, that is wrong, because there would be still couples who have undergone multiple treatments without conception. In reply to this, some senior doctors have advised that it is a doubtful definition, which is hard to defend. It leads to unwarranted interventions and the plethora of solutions that can even decrease the chance of a pregnancy. The very strong words against the whole concept of recurrent implantation failure. So it is kind of a catch-22 situation, because a false diagnosis of RIF will serve as an entry point for us to test for more studies and opt for validity for various RIF treatment. But in case where there is no specific obstacle, we should not resort to any unproven add-on, but persevere with what you have been doing. So what you are doing the same old tests without any evidence. All the steroids, aspirin, GCSF, lit therapy, NK cells, they have been there for decades and there are no answers. But what is missing is we need knowledge on the etiology and we need independent tests which have been validated, both from the receptivity perspective and the embryo perspective. So what do we do? What do we tell our patient? It is our duty to provide them with honest and compassionate counseling about the possible etiologies and future prognosis. You hear them properly, you acknowledge their pain, you respect their concerns, and at the same time you avoid unnecessary tests and interventions of unproven value, which will help reducing their burden, both mental as well as monetary. So, in conclusion, unless you have an obvious etiology for implantation failure, the fourth and the fifth euploid blastocyst would still achieve similar pregnancy rate. And I will end with two very contradictory points of view. This is an old saying that no man can step into the same river twice, for it is not the same man and it is not the same river, which means that no two IVF treatment cycles would be the same. So if you're doing two treatment cycles, you are treating two completely different women, and hence we should not define this as RIF. But at the same time, you should also listen to Albert Einstein that it is insanity doing the same thing over and over again, but expect a different result out of it. So you need to innovate. So two very conflicting views. But I end by summarizing that it is the quality of embryo which to me is the most significant contributor to the chance of implantation. And if you are able to culture to a good quality blastocyst, then carry out a genetic testing, it will lead to a higher pregnancy rate per embryo transfer. You should focus on maternal health and improve lifestyle factors. You will maybe in the near future have improved tools for assessing embryo viability using artificial intelligence. You minimize the external manipulations on the embryo, and we need more research on the concept of endometrial receptivity and more importantly, the embryo endometrial talk, because this is what will possibly open the window for future treatments. So with this, I again thank you all with this Hippocrates oath that first let us not harm our patients, and by harm it means physical, psychological, and financial. Thank you very much. I once again thank Isar, Dr. Monica, and the entire team for inviting me to share on this topic. Unfortunately, I don't have a solid answer to this problem, but I've given you some food for thought.
Thank you so much, Dr. Manish. It was really a treat to hear, and you have covered each and everything. So, just two things which you have brought. We should take care of isthmosil these days because cesarean section rates are going up, and it is another cause of RIF. And, sir, what is your opinion? Should we use recombinant FSH or HMG? Because, as you said, recombinant is more with the LH search. What is your choice and advice to the
I
audience?
think it does not matter. The only issue with HMG or with urinary products is the batch to batch consistency. If you have a batch which is of good consistency,
It was really a wonderful lecture with such a clarity in your thought process because of your sound experience and sound practice as well. I'm so happy that what is to be done and what is not to be done, it depends on that particular clinician and the embryologist. One more thing I would like to stress on is that ultimately, with RIF people, women particularly, you will have to go for blastocyst transfer, which will improve your pregnancy rate rather than any other treatment. Because as it is, the evidence-based such adjuvants or there is no evidence as such for so many things. So only evidence for you is that if you go in for blastocyst transfer, that will be a wonderful thing. And It's a very important thing that you should go for PGD or PGDA. And these 3-4 points are so important and practical. Manish, I'm extremely happy for your lecture. Thank you.
Thank you.
Sir, if we could have given you a standing ovation. It was such a great lecture. Every slide was really precious. And for the benefit of all our viewers, this lecture is recorded permanently on YouTube for anybody who wants to go and watch it later or at any other time. So there is a question from a viewer about non-invasive PGS, NIPGS. Is it something to look forward to in the future?
Maybe in the future, yes, but as of now, the percentage of concordance, which means that if you test the embryo by the invasive method versus the non-invasive method, the concordance rate is only 67%. So in 1/3 of the embryos, you will have a discordant report if you are using the non-invasive PGTA. Because this relies on the measurement of cell-free DNA from the culture media around the embryo. And there is a thought process that embryos have a process of autocorrection, which means the abnormal DNA it will throw out into the culture media. And if you're measuring that same culture media, there is a possibility that you would be measuring the abnormal thrown out DNA from the embryos. So as of now, all societies do not recommend the use of non-invasive PGT testing. At best, you can use it to prioritize which embryo to transfer or not, but it is certainly not the method of choice for detecting the ploidy status, and you should never discard embryos based on this. So I still feel its time has not yet come. Maybe in the future, once the technology gets refined, we would be able to use it, but certainly not as of now.
So then how do we tackle the mosaicism? The
Mosaicism is something different. So what is a mosaicism? It means that one cell has tissue has multiple cell lines. So some cells are euploid, some cells are aneuploid. Based on the percentage of aneuploidy within that particular cell line, it could be defined as low mosaic or high mosaic. If it is below 50%, it is a low mosaic. If it is above 50%, it is a high mosaic. There are two issues with this. One, as I mentioned, the issue of autocorrection. So it is possible that a low mosaic embryo might autocorrect, it will implant and it will grow normally. And we have our own data where we have had 5 healthy live births following the transfer of 14 low mosaic, high mosaic, or sometimes even chaotic embryos. So this firmly tells us that even low mosaic or grossly abnormal embryos could still implant and give rise to healthy children. So the first thing that I tell the patients is that if you have euploid embryos, we will transfer them first. If you do not have any euploid embryos, you can consider doing another cycle, or you could consider transferring low mosaic embryos, but be ready to do an amniotic fluid testing if you are pregnant at 16 weeks to confirm that the pregnancy is normal.
Sir, for poor quality blastocyst, in case if we are not having very good blastocyst whom we can do biopsy on which, so do you recommend going through PGT or randomized transfer you will prefer?
If the embryo is not suitable for invasive biopsy, the only option is to transfer the embryo without a biopsy. So long as it is of transferable grade. There will be a very few percentage of embryos which are not of biopsyable grade but are still okay to transfer. Some C grade kind of an embryo. So these are the embryos you have to transfer without testing.
So would you freeze the best embryos or would you transfer the best?
So, I mean, we do 100% all freeze. So for us, it does not matter. We do a complete 100% all freeze cycles.
So do you think fresh transfer will also come into vogue in the coming 5 years?
So it has a role. Don't think that fresh embryo transfers do not have any role. The only issue is that in clinics which have multiple doctors and large patients, if you do fresh in some, frozen in another. You take the call to do frozen on the day 5. It makes extremely difficult counseling. So to make the whole counseling process streamlined, we follow 100% freeze-all. But in good prognosis patients, meaning no hyperstimulation, good quality embryos, no elevated progesterone, you certainly can do a fresh embryo transfer.
Thank you, sir.
Um, Good evening, seniors. I'm sorry for interrupting. I'm Dr. Gunjan here. Uh, I'm just coming back from OPD and listening to sir. Actually, I just did a scan of a patient who had we did her NIPGT, and she had low mosaic embryos left, and she had just one good quality embryo, and it was a third cycle. The good quality embryo also did not implant in the previous cycle. The patient could not pay any further, so she said I explained her and counseled her regarding amniocentesis and if the embryos implant. So now this time we transferred two mosaic embryos, and two are all surprised. This was the third transfer, and both of them got implanted. I just did her cardiac activity. Both cardiac activities are there. So,
But
like sir said,
I would give you I will tell you a point here. If you are transferring euploid embryos, you can transfer two. But when you are doing a mosaic, you should always do a single, because if you do two mosaics and she has a twin, you will have to do amniocentesis in both the
and
pregnant
both.
and then
Yes, sir.
selectively terminate one. So euploid you can transfer two, but never one euploid and one mosaic or two mosaic at a time. That will, monitoring will be a nightmare.
Yes, sir. And so, good evening, sir. So, I'm Dr. Gunjan. I have received Dr. Manish Banker's award, Clinician Award this year. Just wanted to let you know and
Congratulations.
thank you. Thank you, sir.
Sir, in this webinar, we have got Garima Sharma, who is Manish Banker awardee, and Gunjan
Good
Patki,
evening, sir.
who is Manish Banker Sir awardee.
Good
So,
evening.
sir, we are honored to have you. And I'm very proud to say Perfection Series is having Dr. Manish Banker's talk for the third time. Thank you, sir. Thank you so much for always blessing us.
Thank you very much. Thank you.
Thank you.
Thank you, sir.
So I think now Garima is also there, and we can move to session 3.
Thank you once again, sir. And with this, I think the stage is already set. And today we are going to have truly a cross dialogue between the seed and the soil. One, I always say the two sides of a coin, the embryologist and the clinicians. And to moderate, I have two very close friends of mine, Dr. Sulbha Arora and Dr. Manisha Vajpayee, who are going to take this ride on this black box of RIF today. So can I have Dr. Sulba's slide, please? Dr. Sulba Arora, we all know, is the clinical director of Nova IVF Fertility Mumbai with more than 21 years of experience in this field. She has been a member of the Foxy Presidential Task Force from 2022 to 24, co-opted member managing committee of the ISAR from 2020-22. She has been the recipient of the prestigious MOGS Dr. Shantabai Gulabchand Traveling Fellowship for Overseas Training. And she has also received prestigious awards like ISAR Young Talent Award, ISAR Young Achievers Award. She has 4 books to her credit as the editor with her latest edition of ABCD in ART. I welcome you, Dr. Sulbha. Can I have Dr. Manisha's slide? So Professor Dr. Manisha Vajpayee, my co-convener, again, a very dear friend.
Then we are late for the session.
Yes, I'll just take 2 minutes because she is heading the Department of Embryology and Research at Pacific Medical University, Udaipur, and she holds key positions in national organizations like Managing Committee member of ISAR India, ACE, and Rajasthan chapter of ISAR. And very proud to say that she has 23 peer-reviewed international publications in Index Journal. We have our esteemed expert today, Dr. Chaitanya Shembekar, who's our senior, who's our guru from Maharashtra State chapter of ISAR. Can I have his CV, please?
I think you should skip.
No, sir, I won't. I'll just take 2 minutes, but I have to do this. So there's the chairman and MD of Mega Hospital Private Limited in Nagpur. another hospital and a trust which has done commendable job when it comes to AMOGs and when it comes to MSR, doing a lot of public reach activities through his hospital. And I know that personally, working with him as a member managing committee. Sir has recently been appointed as the Secretary General of the Maharashtra State Chapter of ISAR. He's also the Chairman of Infertility Committee AMOGs. And Sir has had several orations and keynote lectures across 50 Foxy societies and has received the prestigious MS Signature Award in 2021 at the hands of Honorary Union Minister Shri Nitin Gadkari ji. I welcome you here, sir.
Thank you.
And today it's genuinely a cross dialogue between a seed and soil, and we have a galaxy of panelists, senior embryologists, and the senior clinicians here. Can I have the first CV, please? Abhinav Dudeja, somebody from my own hometown city of Amritsar. He is currently working as senior embryologist at Harley Street Fertility Center in Mauritius. He has authored chapters in IVF laboratory procedures, techniques, and key steps, and Manual of Assisted Reproductive Technologies and Laboratory Sciences, second edition in 2025. Welcome, Abhinav.
Next, we have Dr. Amog Chimote, sir. He's medical director at Vasundhara Fertility Center, Nagpur, Maharashtra. We welcome you, sir.
Dr. B. Ananta Laxmi, she is a senior embryologist from Trichy and has also received the ISAR Manish Bankar Young Achievers Award. The next one, please.
Next, we have Apurva Setha. She is a senior embryologist at Indira IVF Hospital, Delhi. Welcome you.
Dr. Gunjan Bhatnagar, congratulations. We just heard about the ISAR Manish Bankar Young Achievers Award for 2025. She's the infertility specialist and laparoscopic surgeon working at Vandeep Gonda. Can we have the next one?
Next, we have Dr. Ishrat Zubair. She is a senior consultant and gynecologist and IVF specialist at Bhopal. We welcome you, ma'am.
Karan Vade, clinical embryologist at London Women's Clinic, Bromley, London. He represented as a young ambassador at 2025 ESHRE, and he's also the ISAR Youth Brigade member.
Next, Dr. Manisha, ma'am, could not join us today. Next, we have Dr. Neeti Vijaya. She is director at the clinic Southex Avaya Fertility Phoenix Hospital. We welcome you, ma'am.
Dr. Ruchi Bhandari, Director, Mishka IVF Center and Bhandari Hospital and Research Center.
Next, we have Sania Kandra. She's senior embryologist at Pristine Care Ferticity, New Delhi. We welcome you.
Tejal Vaidya, she's working as a chief embryologist and laboratory director at Uma Fertility Kalyan. She's a senior embryologist from Mumbai.
Next, we have N.J. Sophia. She's senior embryologist at Akash Hospital. We welcome you.
Dr. Sonal Jain, she's the associate professor at Chirayu Fertility Center, Chirayu Medical College in Bhopal.
Next, we have Dr. Sonil Srivastava. She's consultant at Lake City Hospital, Bhopal. We welcome you.
And the stage is all yours, Dr. Sulba and Dr. Manisha.
So Manisha, you're on mute.
So much, Dr. Garima and Dr. Purva. Dr. Sulba, are you sharing your screen?
Yes, I'll just do that one second. Please let me know if the slides are visible.
Absolutely. You can just go full screen.
Yeah, okay. So good evening, everyone. And now this brings us to the last session of today's program, one that Dr. Manisha and I have been very excited to moderate because this is a topic that lies at the very heart of a subject like recurrent implantation failure, and that is the dialogue between the lab and the clinic. As we all know that implantation failure is as challenging for us practitioners as it is frustrating for the patients. Despite having great embryos, a seemingly receptive endometrium, so many times this magic just doesn't happen. And that is why the seamless collaboration between the clinical team and the embryology lab is not just helpful, it's mandatory, it's beneficial. So today we have the great minds from both sides, the lab and the clinic, to discuss how we can align better, refine our strategies, share insights, and ultimately do what our aim is to give our patients the best possible outcomes to achieve us and sustain a pregnancy. So we've seen quite a lot in detail in the talks given by our previous two esteemed seniors that even though we've come such a long way in the field of reproductive medicine, we have excellent stimulation protocols. In most of our cycles, we now end up with good quality embryos, and yet we see that not every single embryo implants. In almost 30 to 40% of cases, it won't work the first time, and it gets even more frustrating when it repeatedly does not work. And even though, as you know, Dr. Banker, who's also been my mentor for several years at Nova, rightly said, sometimes you just need to do the same thing again because it's not always going to work the very first time. You don't need detailed investigations. But we've all faced this scenario where they just come after one beta HCG negative and they're like, no, doctor, why did it fail? What could we have been doing differently? So now that brings us to the topic. Dr. Manisha will elaborate a little bit more about this.
So, thank you, Dr. Sulva. As clinician, look for systemic or uterine causes in RIF, be it endometriosis. They examine endometrium. They examine immunological suspects. They try to find out autoimmune factor, medical factor, and as an embryologist, it is equally crucial to examine the embryos, its quality, its genetics, and the subtle lab factors that shape its component. So, and it's equally frustrating for us to see the embryos whom we level good or best based on morphology, and they are not being implanted. So we really wonder whether morphology is the real predictor of embryo quality. So today we are going to explore all these avenues. So over to you, Silva.
So as we know that, you need a healthy seed and a healthy soil to give you a healthy plant. Similarly, when implantation doesn't work, we are compelled to wonder, is it in the seed, is it in the soil, or is it in the sower? Is it us? Is there something that we need to change? And then there are a lot of problem areas. We won't go into the details of this. This has been discussed in the previous two academic lectures. But yes, there are patient factors, both male and female. That includes the oocyte, the sperm, the endometrium. And then, of course, there are lab factors. There are clinical protocols. There are so many things where something might not be clicking that needs to be looked into. And now, whereas we clinicians may be the face of the IVF process for our patients, but really the heart of the IVF center is the embryological laboratory. At the clinical end, what we do to ensure that implantation will occur, it starts from a good workup, deciding the correct stimulation protocols, our techniques of egg pickup and embryo transfer, and then at the lab end, because then our IVF program then comes down to being only as good as the lab that supports it. They are responsible for the gamete handling, for the embryo culture, and then that is the responsibility from the lab end. So now
we cannot miss one more factor, the quality of gamete itself. A patient is also responsible for what they are giving us. Sometimes it is beyond our control.
Which is why in the previous one I said that, there are patient factors. Those cannot be neglected. They need to be optimized sometimes. So we are going to keep this discussion very practical. We want to know that what are the things that, this is not a very academic discussion. Like, let's start with the first question. Now, if an implantation has failed, especially if it has repeatedly failed, what we want to know is that how does the dialogue start between the embryology lab and the clinician? What exactly is it that the clinician will want to know from their embryologist, or is there something that the embryologist would like to communicate to the clinician? And we want one of our panelists, anyone who would like to take this question, Dr. Amog, just enumerate the points that you think should be points of discussion, because during the course of the panel, we will discuss some of them a little bit more in detail.
Right. So first of all, first and foremost, that I would like to tell my embryologist is the age of the gametes, both the male and the female. because that is one of the most important aspects that will determine what kind of embryo or a blastocyst we are going to get. Secondly, if there are any other pathological factors, like if there is endometriosis or adenomyosis, or there has been a recent PID in that patient, then this I need to communicate with my embryologist. Thirdly, the ovarian reserve and the AMH, as well as testosterone and prolactin levels of the patient, to that is also again going to determine what quality of oocytes we are going to get. In the male patients, I do tell if there is a grade 1 or grade 2 hydrocele in the patient, so as to change the technique of sperm preparation, and then whether to go in for an IVF or an ICSI for that particular patient. If the patient is a PCO patient, I do tell them, yes, I have around 40-45 follicles, but maybe you might get just 30-40% M2 oocytes. And yes, I do expect that I'll get hardly 30%, 40%, or maximum 50% of blastocysts from those 30-40% oocytes. Implantation rates again will be a big issue in cases of PCOS. Uh, Next factor would be the uterine abnormality in the patient. If the patient has a unicornuate uterus or a didelphys uterus, then yes, I tell my embryologist, yes, let us go in for a blastocyst culture if at all the gametes are good. Again, in sperm parameters, if the age is on a higher side, I do ask my embryologist, let's go in for a DFI, maybe go in for a PGTA, and then go in for a transfer. So these are the basic points that we at our center generally practice.
Thank you, Dr. Amog. I think you have covered that very, very well. So just to summarize that, the critical communication points include embryo quality and development kinetics, fertilization methods. Is there anything in the oocyte factors that is of concern? Was it sperm parameters that they felt were faulty? Could it have been something to do with the embryo biopsy or the PGTA results? Or was it during cryopreservation and thaw survival? And this is how each of those factors have an impact, but we will be discussing this more in detail.
One more point, if I may.
Yeah,
I
please.
forgot the
Yeah.
autoimmune factor as well, because that is also going to determine the embryo quality.
Yes.
Can I add one point?
Yes, please go ahead.
I think we what we should do is, Amog has rightly said, the discussion is very important. So it has to be a dialogue. So what I feel is you should make a list of RIF patients and you should have a meeting beforehand, so that you have everyone is aware that these are the patients who is a case of RIF and you need a special attention in this patient. And then you can start with simple points like sequential transfer. Can we change something? Like suppose we are doing day 5 transfer, then can we shift to day 2 or day 3? Is it going to help us? Then what about the embryo quality? What about the use of AI, which or embryoscope? So you can start with the day of transfer and you can talk about the advances in the embryology lab as well. But then what is important is a dialogue and a meeting before the patient is recruited for the.
And sometimes after that, the patient will come and ask us. Very commonly, we get this question as clinicians, if it didn't work, then they come and ask us, do you think it was the egg that was a problem or the sperm that was a problem?
Right.
Again, this is something that we do ask our embryologists, when they were doing the ICSI, did they find that there was low resistance? Did they find that the sperm morphology was poor? Anything that they feel, or during the embryo development that, was there less number of ferts that happened? Were there good number of day 3 embryos, but not day 5? All these things help us to collect some kind of information which we can counsel to our patient. And as the last point rightly mentions, it's very, very important that the patient counseling must be done, as the previous speakers have mentioned, with a lot of empathy, but the counseling is very, very important. So now we'll go on to Dr. Manisha's questions.
So after the very good first question, let's explore what more we can ask from the lab and how we can refine our embryo assessment strategy. So let's begin by revisiting something we often trust: morphology. What in not the morphology after one or two failed embryo transfer, what embryological aspect should be reviewed? So this question is towards embryologist. Any embryologist, Abhinav, Karan, what embryological aspect should be reviewed after one or two failed embryo transfers?
Can I answer?
I think as okay.
Yes, Sophia.
Sophia, you're on mute.
Yeah, I feel when we are doing the oocyte retrieval itself, that time itself, clinician should have embryologist should have a proper conversation with the embryologist regarding the oocyte quality. As soon as we finish the ICSI, we should have a chat with the clinicians that how the oocyte quality was, like how that granulation plays a very important role, as we see lot of patients with endometriosis nowadays. So we get that even poor ovarian reserve patient also will give us sometimes a very good oocyte quality. Sometimes there will be a lot of oocytes, but we don't get good quality oocytes. So the problem arises from the gametes, and sometimes oocytes are very good but sperms are not good. So I think that regarding that ICSI part, everything should be very transparent between the embryologist and the clinician. So when we discuss that itself, and that day, on the day of ICSI itself, I think it should be very clearly exposed to our patients also, so that they also understand. And after we check the fertilization check, after we do the day 3, after we do the culture till day 5, till the freezing, I think everything patient should be known in a very transparent way, so that it is very easy for us to counsel them. And that is how I think there is only the starting point where we get it. The gametes play a very important role in getting a very good embryos.
Right. So, what all gamete factors you will look while at the time of oocyte?
Initially, I think granulation plays a very important. There are so many patients now. We are dealing with the
Then
central
other than
granulation.
granulation or cytoplasmic factor, anything else you will look?
Yeah.
only-
Even the polar body fragmentation. Sometimes that the zona is very thick, but the zona thickness we can rule out with that because ICSI is a major factor. Then we have that perivitline space with lot of mugs there. So I think those things and all will, everything will, even the resistance with the cytoplasmic thing during ICSI also is calculated. And when even if we are having a recurrent implantation failure, we can change like sperm wash techniques. We can change the next time when we are doing some sort of changes, we can bring out. As sir said before, we can, even when we are trying repeatedly trying day 5 transfer and they are not succeeding, we can try one cycle with day 3 also,
And
so they might get success.
so if I may, one more point, I know from the clinician side, but yes, when we do a pickup and when we look at the tubes and see the color of the follicular fluid, even the color of the follicular fluid, the embryologist can tell, okay, you're getting a bad oocyte out of this.
Exactly.
So that is also one of the aspects that is an indicator.
This is
Yeah,
very
yeah.
serious
So many
subject.
times we get only the cystic fluid, and we even clinician will say there's a cystic fluid is there. When we see the color of it, we ourselves can find out while screening the oocytes whether their oocytes are good quality or not a good quality.
So
Some
you-
sort of expectations will be there, but after denutation only we'll have a proper documentation sort of thing.
Perfect. So you have very well covered, Sophia, about the oocyte quality. So about anybody can take up.
Just one small query, ma'am. Hi, ma'am. Ma'am, just from the embryologist, actually, I was going through this latest Istanbul consensus, and now it has removed most of the oocyte factors. So what is your take on that?
Like Gunjan, in general cases, oocyte factors, we still note down each and every factor because and in case of RIF, these factors are all the more important to be looked upon. So you can't omit them. Although in
Because
general
to my
population,
surprise, they have removed like zona thickness and everything.
in
Even
general,
granules don't matter, they say now. So
in general, you can overlook these factors, but when it is a case of RIF, every detail matters.
Small thing matters. In fact, even if it is not a case of RIF, to take home message for the embryologist, when you have done a denudation and an ICSI, if you find anything in the oocytes that is worth noting down, our embryologists usually tell us once it's done that, the oocyte quality looked poor, or there was too much of granulation, or the resistance was low, because it already kind of primes us in our mind that if this does not lead to a good outcome, this can be the possible cause.
Documentation of each and everything is very, very helpful while reviewing the case. So that will strengthen your data. So please don't overlook these factors. With that, can we move to the next slide? While examining the culture and embryo development, what all factors we should look up? So anybody would like to
I
take up?
think, yes. Just to quickly answer Dr. Gunjan's question, yes, the Istanbul consensus has removed a lot of parameters stating
yeah,
that
which was very
there might not
surprising.
be use.
Yeah, I mean, but if you read it properly, they have said that in some studies, they say that it is going to leading to some problems, and the other study it says that it is not. So collaboratively, they have come to a conclusion that that might not affect the future outcome of the embryonic development. However,
We are
since
talking
we say that
specifically
IVF is
about
very
RIF
personalized,
patients. Here we are
correct. So it's
specifically
very
talking about RIF.
personalized.
Yeah. And with
Yeah.
RIF, we should document. We can't omit. So coming to
Yes.
the next, culture and embryo development, what all parameter we should look? Abhinav?
I mean, for the culture conditions, I would look at the gas levels of my incubators. I will check what media I am currently using and what exactly is the pH. So we have a in-house pH meter whenever a new batch of media comes. Rather than trusting the certificate issued by the media vendors, we do an in-house check of the media pH for every new batch so that we are extra sure. Even for the incubators that we use, we have a 24/7 monitoring of the pH that we use. Along with that, I would also try to look at any fluctuations in the temperature of the lab or humidity conditions. And if my entire cohort of embryo of different patients is growing fine or there is any problem or fluctuations in that aspect as well. And then I would like to
Along
correlate
with
it
that,
accordingly.
blastulation and compaction level, the growth of embryos are very good predictor to
Correct.
check your lab's condition. For embryo handling and transfers, regarding embryo handling and transfer, what thing you would like to analyze? Apurva, would you like
Regarding
to?
embryo, I'm sorry?
No, you can go ahead. Dr. Sulva, can we have the next slide? Because we have limited time, so we are quickly.
Sure, yeah.
So regarding embryo handling and transfer, what are the things you... Sure.
I think temperature is a main point we have to take in account, like before doing transfer. Even that culture media which clinicians are using for that flushing purpose should be in that temperature. Even catheters also we can place it in the incubator for that warm temperature. Temperature will play a major role, and handling also of the embryos. Very like if you are doing laser hatching, should be done and should be kept in the incubator, and then that handling should be not more than 20 seconds or 10 seconds outside the incubator.
And the embryo catheter loading, volume of the media loading inside the catheter matters.
Yeah, it matters.
Yeah,
we'll pick up later because
Just for recurrent IVF failure patient, we can use embryo glue as well. We generally do.
So
Okay.
May I add one
there
point
is
to Dr. Mishra?
abundant evidence that embryo glue has no role in RIF.
It does, but lot of paper talks about its role in decreasing the implantation failure rate.
See, only as in the case of RIF patient, I think we should try everything so that we don't miss even a single step. Even a small step will matter a lot.
Okay. So with that, how does embryo transfer technique impact the implantation success? Have you ever think about that? Okay,
Yes.
embryos were good, and what is your opinion from a lab side? Why always embryo? It may be with the technique. So what points you'll note at the time of embryo transfer, how it has been done? Do you ever notice these points?
Maybe like when a clinician is sometimes a patient will have lot of this one mucus secretion because of that progesterone, or some people will follow other steps of giving that GCSF or HCG injection prior to embryo transfer. Those points might be considered.
And some very
I also feel the mock ET details should be noted down very nicely in such cases, or maybe the history of the previous failures, like it should be noted down very nicely and clearly, so that just before the transfer, the clinician can have a look. Okay, this went wrong maybe at that time, or maybe this went, the other direction. Something was
Sometimes
missing.
patient will
Maybe
have
we
a
should
very
add on.
difficult ET also, so that all has to be, that all will be counted there, which should be documented. I think every step, whatever is being taken care in the lab and in the operation theater, should be documented very clearly, each and every minute step.
And for especially if we are talking about RFI
RIF
patients, we can or RIF patients, we can do ERA transfers as well.
ERA.
ERA again has
That's
more
what we
role.
suggest normally.
We'll be coming back to this question.
If I add one point,
Yes, sir.
actually, if you ask me a question, the question which was asked to one of my fellow student during university exam. I was a co-examiner, and the examiner asked her which is the most crucial step in IVF as a clinician. And she said stimulation protocol. Somebody said starting dose of. So I gave her a hint. You tell me which is the only procedure which you have not done in last 6 months of your 1 year of fellowship, rather. And then she said, "Sir, you have never given us embryo transfers." So we do pickups, we do IUI, we do everything, but we have never done embryo transfer. So I think for a clinician, the most crucial step is embryo transfer. So many embryologists are there; they can tell the most crucial step in their field. They can share with us. But then for us, it is the embryo transfer.
In fact, there are studies which have shown that with increasing difficulty in the embryo transfer technique, there are lower chances of implantation. So, for example, just gentle manipulation of the cuscos may not impact much. But the minute you have to use a stillet or you have to use a tenaculum, then the chances, or there is a fundal touch, then the chances of implantation keep reducing with increasing level of difficulty.
But I think with the increasing use of ultrasound for transfers, I don't think the fundal touch is much of an issue nowadays. And plus, negotiating the
transfer,
canal is
it
also
is
not an issue.
in difficult transfer cases, it is always
Yeah,
there.
sometimes
So,
when the uterus is very
technically, you
adenomatic
can
or so, yeah.
eliminate the difficult transfer by doing a pre-IVF hysteroscopy for all.
And also a mock ET.
A mock ET.
And a mock ET.
A mock ET should be done.
Dr. Amok, I would like to ask whether would you like to do, okay, for transfer, definitely hysteroscopy. Otherwise, should it be guided by a 3D ultrasound or directly hysteroscopy?
See, what I practice in my center is one, I do a 2D ultrasound. If I find
3D?
any evidence that yes, there might be some deviation, a sigmoid shaped cavity or a small endometrioma or a small adenomyoma indenting the cavity, or the endomyometrial junction has been compromised, I put in my 3D.
Okay.
Once in my 3D, if I find there is evidence of endometrial hyperplasia or endometrial edema or increased congestion, then yes, such a patient requires a hysteroscopy, do a biopsy, send the markers, do immunohistochemistry. If at all there is infection or evidence of adenomyosis, subendometrial adenomyosis, treat the patient first, then only take the patient for transfer. It might take 2 months, 3 months, 6 months. But at least you have cleared and made sure that this is the best uterus, this is the best endometrium that is fit for transfer. So you have to counsel your patient regarding this endometrium and the uterus. Even if you give a 4.5 AA blastocyst and you have a poor uterus or a poor endometrium, you are not going to achieve pregnancy.
We'll be discussing more about the endometrium and its receptivity in upcoming slides. So can we have the next question, please, Dr. Silpa? So how a very interesting question for the embryologist again. How should embryologists self-evaluate their performance in RIF cases? There should be some mistake from the embryologist side. So what all parameters you should check while evaluating your performance?
So
do you have something?
First of all, when there are repeated failure cycles, documentation is a major factor. If the documentation is not perfect, you cannot go and then think about what went wrong.
So what factors you would like to document about your own performance?
Yes. So the first thing is definitely oocyte quality and how many number
I'm talking about your performance.
Yes, and how the denudation went.
Yes.
So the quality depends mostly on the denudation.
Maybe the time taken for the
yes, the time period and
for the ICSI.
Who did the denudation? Is it a trainee or a senior embryologist? And then the next major part is how if we are going for ICSI, how the injection went. If it's a loose cytoplasm or there is a difficulty, if it's a thick zona, so if it's a difficulty in injecting the sperm. So these are all the points we note while doing ICSI.
So if in
or even while doing embryo transfer, what was the difficulty faced by the embryologist, like getting a bubble or anything else, like whatever.
We also look for the lab conditions.
Lab conditions should be
are
taken
very,
care. Yeah,
especially
lab
the
conditions.
VOCs and AQI.
Yeah, absolutely. So when we are trying to self-evaluate our performance, fertilization patterns, blastulation rate, ICSI degeneration rate, and contamination trends across the cycles should be checked thoroughly. And the most important point, recurrent lab level issues should be backed by the data, not by the assumption. So documentation and re-evaluation are the keys in such cases. May I have the next slide, Dr. Sulba, please? So coming again towards our gold standard, do you really think does standard morphology grading correlate with the implantation potential, especially in RIF cases? It is open for embryologists and clinicians as well. Good quality embryo, you think there are more chances of implantation? Or morphology alone can be a good predictor? Or do you think using like a time lapse or something AI tool would be more helpful?
May I, Manisha?
Time lapse machine will play a major role. RIF cases, I don't think so. Morphology will play a major role, but it will play a role. But mostly RIF cases will be most of the endometriotic patients. Some other patient profile is a major cause, maybe the major cause for the RIF patients.
Yeah, because the definition only,
May I?
the definition only says that in spite of transferring 3 good quality embryos, it failed. So we cannot just rely on the morphological grading here.
Exactly. It's maybe the
So I
mostly the
think-
But I
patient profile.
personally feel that morphokinetics would offer a valuable data, not in terms of RIF, but all the patients. I think that really does help us predict a better outcome. Not the exact outcome, but definitely a better outcome.
Absolutely. The pace of growth of
So if I
those
may-
embryos, whether they are growing slowly or they are growing too very fast, absolutely defines some abnormalities. So only the morphology should not play a role, but the morphokinetics, the pace of growth, everything has to matter. That's what I feel.
So there's a very old and a famous saying, looks can be deceiving.
Deceptive.
Hence,
And sometimes
morphology alone cannot. But yes, with the AI, with Violet and Magenta, yes, there are predictive models present which are comparing your photos from embryoscope, your videos from embryoscope, and then what embryos or blastocysts resulted in a live pregnancy. Those are being tracked. It is going to take a long time. Machine learning is going to take a long time, but yes, eventually we might get there. But as of now, plainly on morphology, I don't think we can determine whether a good quality blastocyst is going to result in a pregnancy.
And sometimes we have observed that even bad quality oocytes will give very good embryos. It will look
I'll add one point, and that most of the morphologically abnormal embryos do not give pregnancies, but all the morphologically best embryos also will not give pregnancies, and that is the most important point. So sometimes then you really start thinking that what went wrong, because the embryo is so good, endometrium is so good, and then ultimately you land up in RIF. So that is what is the
It's not
difference.
about only morphology, it's about ploidy also.
Exactly.
Absolutely, yes.
To know, are Violet and Magenta, are they available with us right now in
No.
India?
Yeah,
They are. So
in few labs.
But I don't think they're so freely available.
They are not so freely available, and affordability even in time lapse study can help. Here I wanted to put Thomas Ebner's paper, like a good day 2 embryo having 4 balanced blastomere, but if it is in a clover leaf model, it will never give implantation. It was a beautiful study done by him. It was a comparison of almost 800 sibling embryos, and it has been shown. So definitely morphokinetic assessment, so missing out 2 or 3 PNs, missing out clover leaf model, presence of a cytoplasmic string in blastocyst, all these things can be a good predictor in these cases. May I have the next slide, Dr. Sulba? Also, in such cases, PGTA, would you recommend using PGTA routinely for such cases? Because we all were talking about ploidy status. So, would you like to go for PGTA for all RIF cases, for all RIF embryos? What should be?
Mostly advanced age patients, we would like to do PGTA.
Okay. Anybody else?
So PGTA, as most of the Cochrane and all the meta-analysis and the recent paper, I don't remember the name of the researcher, but it suggested that PGTA is only going to reduce your time to pregnancy.
Okay.
It's a selection tool. That's it.
Yeah.
It is a selection tool.
So
So
it
would
is
you
not-
like to use in RIF clinicians?
No.
No. So may I have the next slide, please, Dr. Silva? This is a recent study published in Frontier of Endocrinology in 2023. So it has clearly said that PGTA improved the clinical pregnancy rate after blastocyst transfer in RIF patient aged under 38 years. And can I have the next slide as well, Dr. Sulba? That is again a very strong recommendation published in 2023 June, Journal of Assisted Reproduction and Genetics. PGTA might improve single live birth rate among all age groups and play an increasingly important role in single blastocyst transfer.
I think
Single blastocyst transfer.
Manisha, if you look into the guidelines, RPL guidelines, see
Right.
RPL and RF, they go hand in hand. So
Mhm.
RPL guidelines, they have stressed the importance of PGTA. And I think more and more guidelines are now talking about PGTA, and we should keep PGTA as one of the tool to improve the success rate. So PGTA is now upcoming and has a bright future. And I think we all should start thinking, as you rightly said, going beyond the age factor, which we all see. In 2008, I did a moderator panel on RIF, and at that time also I talked about 38 years age. So we have to move beyond that 38-year barrier, and you should.
Study, they are clearly saying patient it was equally beneficial. It was a study of more than 2000 embryos, and they have clearly mentioned that under 38 years of age PGTA is useful, especially in RIF cases.
I think what we also need to keep in mind that most of these studies are published in the West, and we know now that there is a 6-year difference between our ovarian reserve and theirs. Although this has been correlated more to the quantity of oocytes, but there could also be a decline in quality faster or an increase in aneuploidy rates. So as a clinician,
For us, it is 32 years, right?
Yes. So, and as a clinician, it's not one size fits all. So the main thing in the crux of RIF is your counseling. So we counsel the patients. We tell them if the age is above 37 or 38, PGTA would definitely benefit because the percentage of aneuploid oocytes is going to be too high. In the younger age group, it's something they could opt for, but it's not necessary because also in our country, everything the patient pays from their pocket. It is not covered really by insurance or by the government. The cost needs to be taken into consideration. Some might opt for donor oocytes. They may not go for PGTA. But also, if you have done a couple karyotype and found a balanced translocation or a reciprocal translocation, for those couples, it would be more beneficial.
Right, because cost plays a very important role. Because if you ask a patient to counsel a patient, yes, PGTA will give you a higher chance of pregnancy. The patient counter questions, is it 100%?
And on top of that, what if they are all abnormal?
Yeah.
Then they've lost all that money which they've spent on the PGTA. Plus, when you do a PGTA, you're only going to be freezing one embryo per cryotop. So even the number of cryotops that they are freezing are going to increase.
So as rightly said by Chaitanya sir, yes, it has a bright future, but as of now, since we are doing less number of PGTA, the cost is on a higher side. As and when we go on increasing the number of cycles, maybe the cost might come down and it might be affordable for all.
Yeah.
Right. True.
Next slide, Dr. Manisha. Should I change? Yeah. Okay.
So this question has already been answered by Banker sir because I really wanted to ask. So can we can skip this question? Can we move ahead? The same answer was that. So again, to the embryologist, can suboptimal lab conditions can have subtle influence on implantation potential without affecting the blastocyst formation rate? Do you think so? Can blastocyst formation rates can be misleading? Do you think lab factors matters most for the implantation? Is QC review is must for a repeat RIF cases? What invisible stress might affect the outcome? So
Yes, Dr. Manisha. I mean, in general, lab condition will definitely affect blastulation and everything. Sometimes blastulation will be there, but it's not that great quality of blastulation. You will see the vacuolation in the blastocyst. You will see the fragmentation in blastocyst. There is a number of blastocysts, but not there is a quality of blastocyst. And if you see your lab quality is compromised, you will see the particular, not even the single patient, the batch of the patient might be affected. At that time, you will be definitely your suspected that your lab, that it's not just one patient, it's somewhere my
Bharat,
lab
if
quality
you are
can come up.
dealing with a RIF patient, would you like to review your lab condition QA/QC?
Yes, we always do, and we always monitored from the day 1 to day 5, each and everything. And every morning we have protocol to check the temperature with not just the laminar airflow temperature and something like that, but we have a thermocoupler that we used every morning. We leave it overnight and we checked in the morning. So those kind of minor things we observe each day, and specifically in the batch days.
Right. So can we have the
So I
very
think internal and external audit both should be done, and external
Yes,
audit is more important, especially if you're dealing with a lot of RIF patients.
Yeah,
yes, that's correct.
definitely. But yes, internal audits in RIF cases. Dr. Sulba, can I have the next slide? But it is again a study published recently. It clearly states that implantation success in ART largely depends on the embryo euploidy. While achieving 3 euploid embryo greatly increases the success rate, it is challenging in older women, and they have clearly stated extraembryonic factors, although present, have a marginal impact. But still, we can't rule out the impact of QA/QC in the lab. May I have the next slide, Dr. Sulba? So, do you recommend culturing embryo individually or in group for RIF cases? Do you think culturing strategy can impact the embryo synchrony,
Definitely,
paracrine or paracrine effect, and all those things? Do you think they can play a role in such cases?
as we are talking more about the oocyte morphology and impacting the embryo development, definitely I would like to recommend a single culture. Yeah, at least in order to follow whether it is due to gametes or due to the culture condition. So here, the paracrine and autocrine factors, I don't, in RAF cases especially, I
Mhm.
don't have the belief in that. At least to audit and document and check, go back and check what is the reason, we have to do single culture.
So you are using single culture. So anybody else would like to recommend anything? Because there are
We
these,
we also do single culture, as we are doing 100% time lapse. So we don't do generally group culture, and a single culture in time lapse will give you in detail from fertilization to day 5 growth and everything. So I think if you are using time lapse, and the single culture is the always best, because you can check
so if
from
you are
from
not using time lapse, then do you think paracrine and autocrine things can impact embryo on embryo growth? Anybody?
Mm.
And or everybody is in favor of single individual
No,
culture?
I do group culture,
Yeah.
but basically I just group them as M1s and M2s.
Mhm.
Unless the M2s also show me some kind of indications, I just keep them in single. Otherwise, till day 3, I group them in group, and later on, maybe if I feel, I might shift as a single culture. But that's not
Okay.
on regular basis. Mostly, I go for group culture, and I am happy with that also.
And in RIF patient, you will go with the same approach. You would like
With
to
the
go with,
same. Yes,
yeah.
unless I'm planning for
Yeah. So in
NIPT or
our
biopsy, something like.
Okay. So
Yeah.
if we look at the evidences, again, I would, Dr. Sulba, may I have the next slide? It is again a study published in Reproductive Science in 2024. It clearly states that implantation and pregnancy rate were similar regardless the type of embryo culture. But having said that, individual culture may increase blastocyst formation rate and may benefit embryo quality on day 5. So may I have the next slide? But it is a beautiful report published in Cell. In that, they have stated that this is something a dream or something we are looking up to, advanced dynamic culture system mimicking fluid mechanical stimulation in the oviduct through vibration, tilting, microfluidic methods, and the use of innovative softer substrates hold promise for optimizing in vitro embryo development. May I have the next slide? In unexplained RIF cases, do you recommend change the embryo transfer strategy? Day 5.
yes.
So
Yes, maybe suppose if you're following only day 5, we can shift it to day 3 and see for one cycle.
what is the
Something,
logic behind that?
maybe sometimes maybe the endometrium is might be receptive, just because
I
she's
would like
already
to have
undergone some 2
Canadian
times.
opinion here. Do they feel it can be beneficial? Dr. Amog, Dr. Gunjan, Dr. Niti, if they blastocyst transfers are not working, would you like to go back to day 3 transfers?
So if I may, if anyone
Yeah,
else
sure,
wants
sure,
to
sure.
answer.
Yeah.
Yeah, okay. So we do 100% blastocyst transfers.
Mm-hmm. And
And
they are not working in such scenario.
so then yes, then such a patient can be taken up for PGTA to check for the ploidy status.
Mm-hmm.
If not, then go back again, reevaluate your uterus. So it is not always the blastocyst or the embryo which is causing the problem. It might be some factor which we deem it as unexplained infertility. The air quotes being it is not unexplained, it is under evaluated infertility. Yes,
Sir,
there are certain factors which are still not understood.
mm-hmm.
Those can be labeled as unexplained, but maybe some factors might have been missed while evaluation.
My question is very simple. And
One,
sir,
one.
I want
I
to
would,
yeah,
yeah,
sir,
I would
please.
like to add one point here. If you go through the previous edition of Gardner, they have specifically said that there are studies which say that in diminished ovarian reserve, day 2 embryo transfer may work better than day 3 or day 5 embryo transfer. But then
Mm-hmm.
now the latest trend is all the guidelines. They clearly say that day 5 has an age over day 2 or day 3. But then previous edition Gardner has mentioned about day 2 embryo transfer also, right? So think of so we don't discuss about day 2 embryo transfer, but he has specifically mentioned day 2 embryo transfer. So you have to take into consideration the ovarian reserve of the patient as well.
Mm-hmm.
And second point is sequential transfer. And though I am not doing that, but then I know there are many clinicians who are, they are very much for sequential transfer. So sequential transfer is one more thing which can be taken into consideration. And the ovarian reserve has a role to play on day 5 or day 3 embryo transfers. So how
Dr.
many embryos you get and how many embryos do you think you may go up to day 5? And there is one very important point which is which you think of, that uterus is also a very good incubator. In fact, it's a natural incubator. So some people they argue in such a way that uterus is a natural incubator. So why not keep embryos in the uterus instead of keeping it outside? If you're not getting good results with the day 5 embryo transfer. So uterus is
So
also a good incubator. In fact, it's a natural and the best incubator.
But
I agree with
Dr.
sir.
Chaitanya, what I counter to that is that on day 2 or day 3 in vivo, the embryo is not in the uterus, it's in the fallopian tube. So you're putting it into the wrong environment, actually. I think that the favoritism towards day 2 or day 3 transfer initially, like you're saying, older editions of Gardner, probably came from the, wondering whether there could be an epigenetic impact on long culture.
Right.
But I think now the previous few years of research have quite
Everybody is talking about
clearly
blastocysts.
proved.
Guess incubators.
Another point in favor of day 5 would be the lab condition is relatively suboptimal to what the body can provide. So if an embryo can grow to a blastocyst in a relatively suboptimal condition, and the embryo might be slightly slow, or maybe because of the ovarian reserve, you are going for a day 2 transfer, day 3 transfer, thinking that the epigenetic changes and the natural environment may help in implantation. That has been still under a lot of flack, and day 5 has been the one which has been recommended by most of the guidelines, including the recent ones, that especially in RIF, day 5 transfer is the way to go. If you have a failed previous day 5 transfer, maybe going for a PGTA, check for the ploidy status, and then transfer.
But the message is
There is
loud and clear.
one more fact.
Day 5 embryo is the best. The message is loud and clear. That
One more practical issue with this approach, like we have already frozen our embryos on day 3 and on day 5, suppose. And if we are doing, there is a practical impossibility of doing a day 3 transfer. So we have to stimulate the patient entirely again. So when we are changing the stimulation protocol, we are not justified in comparing the same cycle. I think that.
I can't get
Because
you.
the embryos are already frozen and must have frozen them on either day 3 or either day 5. So, how do we compare the same cohort? So, when we are re-stimulating, we have to do the
So we're not
stimulation
talking about
again. So, that's
re-stimulation, we're
an
talking
entirely
about the
different
same cohort.
cohort.
We're talking about the same cohort. Day 5,
But we have
day 3,
already
the next
frozen. We
cycle,
must
day
have
2, day
already
3 again.
frozen them.
So would you prefer to freeze on day 3 and transfer, or freeze on day 5 and transfer? That is one question. And if you're doing a fresh transfer, would you already transfer on day 3, or would you wait till day 5? That is the question.
So generally, we do wait till day 5.
I think that is what most people are now practicing. Also, because most embryos will reach the day 2 or day 3 stage. There is a natural selection after which, the most of the aneuploid ones might not grow up to the blastocyst stage.
Right.
There are a lot of advantages for blasts. They've already been covered in the previous 2 lectures also. Better synchrony between the endometrium and embryo, more relaxed state of the uterus. So I think most people are more comfortable going ahead with blast transfer as compared to transferring at cleavage stage.
And just one small thing, since we are discussing the transfers here, fresh versus frozen in RIF cases, what is the consensus?
Would the clinicians like to take this up?
Frozen.
So we go in for a frozen transfer for
Yes.
most of the patients to have a better development of endometrium, have a good synchrony, have all the parameters evaluated. Many a times an IVF cycle is done irrespective of the uterine status. Many times there might be a small arcuate or a septate uterus or a chronic endometritis or endocervicitis. In such situations, you are not going to get a positive pregnancy in fresh cycle. So might as well extract the eggs, make an embryo, make a blastocyst, freeze it, optimize the uterus, and then transfer.
Also, because during a stimulated cycle, the hormone levels are supraphysiological. They're not clearly as, they're like the natural state should be. So when you do a frozen embryo transfer, there are also now a lot of studies saying the benefit of doing a frozen embryo transfer in an unstimulated or without HRT in a natural cycle. So I think there are clear benefits of freezing and then transferring in a deferred cycle.
So even in a frozen cycle, mostly what we are practicing now is a modified natural or a natural cycle FET.
If you look into the ovarian reserve uh, part, it is there are many. I would like to mention you here that I don't do fresh transfers. We are definitely for frozen embryo transfer. But then those who are ardent supporters of fresh embryo transfer, they have this protocol which they follow. I have seen many of them doing that. That if the ovarian reserve is low, and if you are stimulating with a soft protocol, and then that is where you don't expect the embryo endometrium to get advanced because of the supraphysiological levels of E2. In that situation with less number of embryos, the fresh transfer gives you better results than the frozen embryo transfer. That is what the supporters of fresh transfers say. But again, here I generally what I do is I give them option of embryo pooling, because if you have a low ovarian reserve, then why not go for embryo pooling? And then the segmentation of your transfers is always giving you better results. But then fresh
Also,
transfer definitely has a role to play, and I've seen many people supporting fresh transfer, especially in patients with diminished ovarian reserve.
Also, in pooling cycles or minimal stimulation cycles, if you're using clomiphene as a part of your stimulation, then I don't think it would be ideal to do a fresh transfer.
You cannot.
Right.
Yeah, one cannot.
So can we move to the next slide?
So I think a lot of this has already been covered, but where do you think we stand right now? AI has become the hot topic thanks to social media. Every time on social media, we are reading that first AI baby has been born and things like that. And then patients are coming and asking us, do you do AI? So what would the embryologist suggest, that are we there yet where, it has definitely got an edge over not using it, or where are we currently?
I think due to the cost factor, many centers don't have that time-lapse machine.
Yeah.
Very few centers have. So that may be considered.
And I think also these guidelines that were discussed already also by Dr. Monica as well mentioned that yes, blastocyst transfer can be considered. Laser assisted hatching is not recommended, but in the subset of patients older than 38 years, it did show a benefit. PGT can be considered, and as far as time lapse and AI are concerned, the latest ASHRAE good practice recommendations also mentioned that they do show promise, but they still need to be evaluated because
Even ChatGPT says that not all things that they say is correct. So AI has a long way to go.
Yeah.
Yeah, that's right. That's another problem now. Patients reading ChatGPT and coming and telling us what to do because they think that the ChatGPT is better than us. Dr. Manisha?
Yeah. So can repeated failure of euploid embryo be purely a lab issue?
No, only partially. I think everything cannot be put over an embryologist or to a lab. And there is a correlation.
Evidence
As we
perspective
dis-
on this.
It has to be
as we
interlinked with the clinician, with the patient profile, with the embryologist, and with the lab factors.
as
Okay.
we discussed, age also plays a very important role in euploidy and non-implantation of the embryos.
Age, patient profile,
As
their
you said, the patient, factors play a very big role. As I was just mentioning, that they now think that AI and ChatGPT are the answer to everything. I had a 43-year-old patient who came today. She's undergone one previous failed IVF cycle outside, and before that, 4 years back, one IVF cycle with me. Rather than understanding the impact of her age on the oocyte quality, she comes to me with a whole list of questions. Doctor, this time please use low dose stimulation because I will get more euploid embryos if you do that. And this time please use Zymote.
oh
Like
my
she's
God. Oh my God.
so I think one of the things that stands in the way of implantation is the patient themselves, and that is why the counseling becomes so important because they think everything they've read on the internet is correct.
Actually, and now they have a home semen analysis or home IUI kits.
Yeah.
God knows, in few days they start doing their own home pickups and
So now there are commercial kits available to check your own sperm count.
I know. So sperm count and
On
even
mobile, on mobile,
home
On
you
mobile.
IUIs are in trend. So very soon,
use your mobile camera.
I believe. So may I have the next slide? Yeah.
So we had this whole discussion about the seed, and now coming to the soil, I'd like to ask the clinicians: do you think that are we investigating the endometrium enough, or is it being over interrogated, or is it just being ignored in RIF cases? Dr. Gunjan, would you like to take this question?
So yes, ma'am, endometrium is the most important thing we should be looking for, and the HRA guideline also. There are just three factors which should be looked after: the lifestyle factors, the endometrium, and the APLA status, the antiphospholipid status of the patient. So endometrium is the thing we should be looked for. So we should be doing a hysteroscopy, whatever modalities we can do. We have to rule out chronic endometritis. We have to look for small polyps and small fibroids intending the cavity. So all these has to be taken care of.
Absolutely. So the green, as Dr. Monica has mentioned, this color coding, where in the green it mentions that reassessment of endometrial thickness, particularly. How much was the thickness in the previous cycle? Do we think that we had a good thickness, or what can be done to improve that? And in the orange, what can be considered is further testing, maybe with a 3D ultrasound or a hysteroscopy. And chronic endometritis testing and endometrial function testing have also been included in that. Whatever is mentioned in the red is considered as not recommended, but they specify that, see, these guidelines were made by an expert committee and their interpretation of data. A lot of the data is largely lacking.
Yeah.
It has not got a strong evidence. So they did mention that the ones in red imply that this is not routinely to be offered, but it does not mean that it cannot be used in under any circumstances if you feel that these things might benefit. But yes, under the green and orange, we do have reassessment of endometrium and looking at endometrial function testing. So, yeah.
If I may, yeah,
Yes, please,
there's
please.
a superb, as in one of my favorite papers by one of our own, Dr. Deepak Modi, Love in Times of War. It so beautifully elucidates the interaction between the blastocyst and the endometrium, and all the endometrial and the pro-inflammatory and anti-inflammatory factors that are present in the milieu which are affecting the implantation. So I don't think we should discredit the natural killer cells and the pro-inflammatory and the anti-inflammatory factors, as well as the immunology, that is Th1, Th2 immunology.
Yeah, it does clearly have a role to play, especially as you said, Th1, Th2 immunology, because in the tissue of repeated implantation failure or even miscarriages, it has been found to have a pro-inflammatory effect rather than an anti-inflammatory.
So, very recent paper, 2025 Feb, again, it suggested that the CD56 counts in a basal layer of placenta of a term pregnancy was significantly very less as compared to a preterm labor or a early trimester lost placenta. So,
Also, yeah.
CD56 does have certain role. maybe at the time of implantation, maybe later during the developmental process of the placenta, which may further may cause pregnancy hypertension in such patients or early trimester losses.
Do you think any lifestyle factors can have an impact on either the oocyte or even the endometrium quality? Would somebody else like to, Dr. Ishrat, would you like to throw some light on that? Dr. Ishrat there? Dr. Neeti, one of you?
Yeah, lifestyle factors include if the patient is having a high BMI, definitely it affects the implantation also and the egg quality as well. If she's into smoking, excessive caffeine intake, and alcohol, then that also affects the egg quality and, of course, the implantation because of it affects the blood flow to the uterus as well. So,
Yeah,
yeah.
some of the lifestyle factors that have been shown to have an effect. The first thing that I tell my patients, they come and ask us, do we need to give up non-veg? Can we eat dry fruit? Can we eat eggs? So we always tell them that those are actually myths. What you need to eliminate from your environment completely is chemicals as far as you can. Though you cannot eliminate it completely, we live in a world where we are exposed to more than 20,000 chemicals in everything we eat, drink, and breathe. But for example, as much as possible, eliminate the use of plastics, because the minute you're using plastic bottles or containers and put a liquid or food in it, it is already secreting a chemical. And now there was a recent study where they compared the placenta of 100 women who had a preterm birth as opposed to 100 women who delivered at term. And the preterm placentas had a very high concentration of microplastics. Microplastics have been found in the endometrium, in the follicular fluid, in breast milk. So this is what we have done with our environment. There was a very interesting another study about the circadian rhythm, because they took a group of women who do late night shifts like cabin crew and nurses, and they found that in those women the risk of implantation failure, endometriosis, PCOS, ectopic, and miscarriage was much higher. So that's another thing we explained to them, that you need to sleep from the correct time to the correct time, because your body's hormones are going to respond to sunset and sunset cycles, sunrise and sunset. So though there are the common things that even patients are aware about BMI and about smoking, but these small things like, they tell them, but we don't have any chemical exposure. We just eat, normal food cooked at home. I tell them even a bottle of ketchup has preservatives. Everything that you ingest is a chemical. Yes, Dr. Ramo, please go
Yeah,
ahead.
so we had a very good CME of respiratory medicines and gynecologists. So there was a very interesting paper they mentioned and quoted that a AQI of more than 200, we are inhaling so many chemicals that it is leading to secretion of lot of endocrine receptor chemicals. And these are altering your entire endocrine parameters and causing endocrine dysfunction. One important was that there was an increase in prolactin levels in patients living in the areas where the AQI was more than 200. So, as simple as the air we breathe is something which is affecting our fertility potential.
So, and we do find very high incidence of high prolactin levels in our patients when we test. So just, one take-home message is that there is a very interesting book called Our Stolen Future by Theo Colborn. It was recommended to me by Dr. Rupinshaw almost 15 years back. It's a must-read for anyone dealing with the healthcare field or especially reproductive medicine, which tells us how, because of the environment we live in, our stolen future, because we are heading towards our own extinction, increased incidence of... Sorry, sir?
What did you say? The name of the book?
Our Stolen Future.
Okay,
It's available on Amazon. It's an eye-opening book. And increased incidence of infertility, malignancy, and homosexuality compared to the previous generations. This is the impact of our environment. It's a very, very eye-opening book, and it does give you a lot of answers. It helps you to counsel your patients better, because when you're aware about the impact, you can tell them about things which they can at least try to avoid.
The same thing when we talk about microbiome profiling, which is in train, and we try to correct uterine microbiome. Uterine microbiome is basically controlled by your gut microbiome. Your eating habits impact highly on your estrogen production levels. Like the bacteria which are responsible for estrogen production and control estrogen cycle, they are being governed by your gut. Dietary fibers, they have a butyrate, which is being produced by the fermentation of dietary fibers. That is the main component which control your estrogen progesterone cycle synthesis and regulation. So all these things have a role which we can't see as of now.
Yes, in fact, last 2 years there's been a lot of discussion about dysbiosis at both ASHRI and ASRM. If we have 10 trillion human cells, we have anywhere between 10 to 100 trillion bacteria that live with us,
And
without which
yes, they are always 100 times higher than our
100
own
times
cell.
higher. In 5 parts: on the skin, in the mouth, in the oral cavity, lungs, gut, and in the vagina and uterus. And though microbiome profiling is difficult to do, it's not accurate, but the probiotics are easy to take and they don't have side effects. So that's one of the things that can be suggested for improving the uterine microenvironment.
Definitely.
And again, this is from the ASHRAE latest guidelines, which, as far as endometrium is concerned, reassess the endometrial thickness, review the estradiol treatment regimen that you have used. You could do a hysteroscopy to rule out Asherman's. Endometrial receptivity function testing and chronic endometritis are in the orange, but they don't feel that Doppler measurements really have much of a role to play.
But I think Dr. Sonal Panchal's paper and the chapter, they have correlated very beautifully the role of Doppler, especially the RI and the SD ratio, which will give you a good vascularity, and then correlated them with the live birth rate and the clinical pregnancy rate.
I was
So
about to
Doppler, especially the
blood flow.
subendometrial blood flow and the RI, is
Yeah.
very important in determining what the outcome can be.
And this is why it's so important for us Indians to publish more papers. We do so much more work in the West. We don't publish quite as much as them.
Right.
And very often we do find racial differences because of the environment and things like that. So you should always do, also follow what in your experience you have found to be beneficial, not just go by what the Western data suggests, as far as what you're using in your practice, as Dr. Banker said, primum non nocere. It's not harming your patient and not even harming their pockets. It's not extremely expensive. It could be worth trying. So now we'll come to the next question about the ERA test. Now, how do you decide when to proceed with an ERA test? Is that what is required, or should the focus be on more embryo quality in a given patient? Dr. Ruchi, would you like to take this question?
I think she's not.
Dr. Sonal? Dr. Sonal Srivastav? Okay, Dr. Ramo, would you like to take that question?
I don't do ERA. I don't believe in ERA.
Okay, does
What
anybody
we
else?
biopsy in one cycle and we extrapolate it to the next or the subsequent cycle. So unfortunately, I do not believe in ERA, so I don't do it.
Okay,
Same here. Same here. I don't do ERA.
Dr.
It is
Chethan,
said,
would you like to give
Actually,
your
can
it
I
is
say
said,
something?
it is
Can I
said,
say
yeah,
yeah,
something?
Monica,
Dr. Monica, please. Yes.
Yeah, I think the absolute authority on ERA is Dr. Nalini Mahajan.
Yes, she has done a very large.
She was the one who was one of the pioneers who used it. She
Yes.
presented a lot of data from her own center. I think it was Mother Care or something of that hospital in Delhi. So, to the effect that we really thought that it's useful, and then we extrapolate with the companies, we came down to a very acceptable cost of around 60 to 80,000 for ERA and all that. Started classifying the endometrium. But having said that, data has come out now that you are subjecting the patient to so much of testing in a previous cycle. And next cycle, the same sort of receptivity might not hold true. And there are other factors in the endometrium and receptivity which should be studied along with this particular gene transcription, which Manish Banker sir also said. So
as the guidelines now, yes, as Monica, you have mentioned about the guidelines also in the previous talk.
Yes,
Guidelines now say that ERA itself is not sufficient.
Yeah.
You have to go beyond ERA and do more to know the implantation potential. So
So
ERA,
there is no there. Sorry, so you were saying?
No, please go ahead, please.
Yeah. So as of now, there is no non-invasive test which is going to determine the receptivity of the endometrium in the active cycle. So as long as we do not have that, I think this is one which was tried, but extrapolating the result or report of a ERA in one cycle to another one and expecting it to be the same as you got in the previous cycle is something which is just a Hail Mary for implantation.
So
So
what
can I say something?
yeah, please.
So we used to do ERA in the past when we had very good embryos and very good endometrium, and still there won't be any implantation. So we did get few pre-receptives and post-receptives, and they actually helped us. But over the years, we have stopped doing ERA because most of the patients, they were coming receptive. I don't know how.
Yeah.
So this was my point here.
So I think the key points to keep in mind, first of all, is that most of the cases of reproductive failures are more likely to be due to embryo incompetence than due to a shifted window of implantation or lack of uterine receptivity. To the percentage of almost 70 to 80% cases, it's the embryo, and in lesser number of cases, you would find a receptivity problem. So this test, even if you want to do it, is to be very judiciously selected who you would want to offer it to. As Dr. Monica said, it's expensive. It has come down now further, 45,000, but it is still expensive. And why that cost is not justified is because when you do that test, 85% of patients will end up with a receptive report. What did they achieve by spending that 40, 50 or 60,000? Nothing. They are back to square one. So it is not to be offered to everyone, but this is from the ASHRAE guidelines. And here they said that almost 60% of clinicians do consider that it could be a shifted window of implantation, and they do offer it. I would personally offer it only in cases where self-cycle transfers have failed, embryos were of good quality, then donor egg has tried and that has failed, because then that means there could be somewhere a problem with the window of implantation. This is how the report comes if you actually do it, and it will tell you whether it is pre-receptive, receptive, or post-receptive, and then help you to personalize the embryo transfer, the duration of progesterone, but in very judiciously selected cases. Also, the theory behind this, the research seems to say that you have to mimic exactly the embryo transfer cycle when you're doing the ERA, and then if that is done, then for some of the studies say even up to 3 years the report is not likely to change. But yes, it is not for everyone, it is expensive, and even this is like our data. I've gone through Dr. Nalini Mahajan's paper. She had very similar results, that receptive, they found receptive in almost 85% of patients, even in hers. But what they found is that in compared to the patients who did not have recurrent implantation failure, if you divided this subset into the ones who had recurrent implantation failure, the incidence of non-receptive ERA was much higher. And then by doing a personalized embryo transfer, they did get a success where previously it had not worked. Again, because numbers are small in most studies, it is difficult to prove whether did the personalized embryo transfer help or would they just have conceived anyway. So I think that is where ERA stands right now. The theory probably made sense that it could have a shifted window. In practicality, if at all you're doing it, very judiciously selected patients. Okay, so now we come to the next gray zone. There are so many adjuvants in the market, and what are your favorite ones, and which one do you use, which one do you not use? Would all the clinicians like to tell me one by one what they use, if they use anything at all? Amog?
Yeah, okay. So we use all of them in some sort of combinations. Because this is many times you do everything and there are some unexplained factors which are not working.
Yeah.
And maybe sometimes an L-arginine or intralipids. Apart from endometrial scratching, maybe I use most of them.
I think if we've done a hysteroscopy, it kind of works as an endometrial scratch anyway. And
I
why
think
we
hysteroscopy is more useful, Dr. Sulba, because of the distension it causes.
Yeah,
You know,
that also.
subtle distension opens, like maybe leads to a better vascular endometrium the next few cycles. So maybe that
No,
works.
hysteroscopy, I would say the reason I do a hysteroscopy is one, to biopsy, do a targeted biopsy, because many times in patients who are having RIF have a very patchy or a very isolated, maybe a strawberry lesion or IISC type of type 1, type 2 type of endometrium, which is missed on sonography, or even endocervicitis is sometimes missed. You have a very proliferative or hypertrophied endocervical glands which might be missed on ultrasound. So hysteroscopy does help in such situation. Scratching, there have been papers which initially suggested that yes, it increases the anti-inflammatory factors, it increases the vascularity. But then again, when a long-term study was done, the meta-analysis showed that it had hardly any change in the vascularity or decreasing the pro-inflammatory factors. So scratching or hysteroscopy as a tool to improve the receptivity is something which is still debatable. And me personally, I'm not convinced and I don't do a scratching, but yes, pre-IVF hysteroscopy to rule out IISC, that is impaired inflammatory state of endometrium. Yes, especially in Indian subcontinent women, it is a must.
I think in the field of reproductive medicine, every 6 months there's a new kid on the block. So some years back, everyone was excitedly doing endometrial scratching, and then everyone was doing intrauterine GCSF, and everyone was doing PRP. And now I think most people have realized that they don't really help. Anybody else would like to add, Dr. Neeti? Any adjuvants that you use?
I agree with Dr. Amog that we do use all of them in some form or the other. Hysteroscopy, whenever we do, it's kind of whenever you enter through the probe, थोड़ा बहुत scratching तो हो ही जाता है. So I agree with Dr. Amog on this.
Dr. Gunjan, you would like to
No, no.
add?
I think I use the less costly. I use ecosprin in most of my patients because it is supposed to increase the uterine blood flow and improve the quality. Also, in patients with very thin endometrium who are repeatedly showing me a thin endometrium and they had one or two failures, I sometimes add this enoxaparin. So that is one thing I do give.
What I do use quite commonly is probiotics, and in
Yeah. Yes,
select
that too.
cases, and amino acids, but in select cases, intralipids. Also, the ISHRE guidelines say that compared to LIT or intravenous immunoglobulins, it is supposed to be safer, less likely to lead to complications, and of course, it's more economical as well. So I think most of them don't have any consensus about what would work. But in our practice, sometimes the patient will come to you and say, "Do whatever you can do. This is my last attempt. After this, I have no more money or energy left." Then what do we do at that time? We would want to try everything that we know at least won't harm her. Let's give it a shot.
Yeah, so IV immunoglobulins, they are costlier, and so we have used I have used Bharglobe also in many of my patients, and it has given results. I don't know whether the results were because of it, but it has given.
Correct.
So we do use steroids as well as
Yeah.
adjuvants.
Yeah.
Steroids, I don't.
And this again, as the previous distinguished speakers mentioned, of course, ASHRAE guidelines have put them all in red. But then, like they mentioned in their guidelines, it doesn't mean that you cannot use them. It's just that there is no evidence in favor of them. So now we'll come to the last part of this. We've got three very short cases. So let's look at the first case. Now, this is a case of euploid embryos and no implantation. So 34-year-old woman, she has 3 failed embryo transfers. All were single day 5 euploid embryos. ERA was done. It was receptive. The hysteroscopy is normal. So what next? Anybody who would like to take this question? Dr. Ruchi and Dr. Sonal were not there earlier. Are they around now?
I don't think they are there.
Dr. Neeti?
If
Dr. Amog,
if
anyone?
PG
Dr. Neeti, can you please.
Yeah, so she's a young patient. She has failed euploid embryo transfers. Even the ERA is receptive. The soil is good. The seed is good. The hysteroscopy is normal. So I would like to reevaluate the lifestyle factors. Whether she is whether how is her lifestyle, like if she's too much into smoking, caffeine, or reevaluate her BMI. Number one. Number two, I would like to know. I would suspect any immunological factors working here, and would like to intervene with the would like to intervene with the things like intralipids, bar globe, or may think of lit as well.
Right. And these are factors that we have already covered, dysbiosis, etc. And immune modulation as well, as you
So
just
one
said.
more important aspect I would like to check for is the endocrine status of the patient. Many times the progesterone, the OHP, the DHEAS levels do not match the transfer levels. So if you have a endocrinological dysfunction or dysynchronous endocrine system, you may not have a good implantation.
Sometimes, it comes down to the smallest of things that the patients might have failed to share with us also. Because when everything seems to be normal, what else could it be? I recently had a patient who was on her second embryo transfer. The first one hadn't worked. And she came and told me, Doctor, that progesterone pessary, it leaks out. So I dip cotton in Ayurvedic oil and stuff it into my vagina to ensure that the progesterone
Oh my
pessary doesn't.
God.
Yeah. So sometimes, it stumps us that we have thought of everything, and maybe we failed to ask a few extra questions, or maybe some information she did not share with us. Now, we don't know what that oil contains, what impact it might have had. So there can be so many other factors in the patient's daily habits and lifestyle also.
So I also had not a similar one, but experience regarding Ayurveda.
Yeah.
Patients do come, they tell all the history, and then one fine day a patient comes and tells, I had done a bhasti. Bhasti is like pushing in oil through the cervix into the uterus in order to cause fallopian tube recanalization. So she had done it 4 times, and
Oh,
that had caused problems with her endometrium, and hence the failures.
yeah. Yeah. So there are these factors as well that get overlooked sometimes.
So
So
how can the patient go up to the cervix? It's very surprising, huh?
quacks in this country are
No, no,
doing
the quacks do it. They did undergo the procedure
The
called as
the
bhasti.
quacks are
Yeah,
doing
yeah,
it.
yeah.
Yeah, yeah,
But
yeah.
I did get a question from one of my patients about self-insemination at home.
Yeah. They are doing it
There, I think they just put the unprepared
intravaginal.
semen in the
Yeah, raw semen they put it in the vagina.
Yeah.
vagina. That's, I think, very some old method, no?
Yeah.
I find it more often in couples who are just not able to have natural relations at
Yeah,
all.
but that's an official, like it's a scientific method
Yeah.
in those cases. But otherwise, now it's being advertised in
Yeah.
some sort of social
Yeah.
media.
Yeah.
Another thing I wanted to comment was, Dr. Sulba and Manisha, you had a very elaborate discussion on embryo loading, transfer. But actually speaking, RIF has already sorted out that you are using state-of-the-art facilities.
Right.
Your embryo transfers have overcome all difficulties related to the lab, embryo loading, transfer, then the time interval between pickup and ICSI, the time interval between catheter loading and transfer, and difficult transfers by experienced trained clinician and embryologist. So RIF does not take into account all those factors as putative causes.
Absolutely. Actually, Dr. Manisha and I did discuss this also before incorporating these, but what we thought that there might be some
No,
people
no,
in
yeah, but see, everybody has got a different experience. You can't go for perfect. In India, which patient will stay with you for 5 cycles? Nobody does.
Yeah.
Right.
Yeah.
So they have a difference in the lab and clinician, and everywhere it's a difficult thing.
Yeah.
I just did tomorrow. I'll be doing IUI for a patient through in the IVF OT in my pickup OT with a very flexible sort of spring made catheter because her cervix is totally tortuous. She has history of 3 failed IUIs and 1 failed embryo transfer in Bhopal. So she came to me that I have a non-negotiable cervix. When I tried doing a trial, I could not do it with an IUI catheter. I had to take her to the theater, keep a partially full bladder, apply a tenaculum, straighten the cervix, and still I could negotiate that tortuosity and the isthmosile niche only with the help of the metallic outer.
Right. Yeah.
So this happens sometimes because of hydrogenic factors also.
So, ma'am,
Yes.
this is a very good point you took out about the niche. So nowadays, if a patient has a RMT, that is residual myometrial thickness of less than 2.5, we do recommend that we correct it laparoscopically because it is going to distort the cervicouterine angle, and most of these uteri are retroverted. So negotiating a catheter in such sigmoid shaped or a angulated cavity is very difficult. So it is always better to do it laparoscopically, correct the defect, resuture it, and then resuspend the uterus with the round ligament, plicate it so that you try and make it antiverted and have a good angle at the time of transfer.
So
Actually, I
actually
have
about
embryo transfer catheters. I don't know, Sulba and Manisha might be knowing. In the previous years, X-rays, about 10 to 12 years back, There was an Austrian company which made the outer metallic catheters, which have got multiple, around each catheter has got about 100 tiny springs all along the distal end, which goes followed by a very gentle small bulb. So it literally, that's like that's like an AI. It literally tracks any cervix in the world. So till to date, I have never had a difficult transfer because of those. First, I outsourced two, then I bought two more, then I bought two more, then one again. So I'm the proud, I have, the owner of 7 of those catheters, and they are a blessing. I don't know whether they are available in Ashray now.
Yeah, Dr. Monica. Actually, so we included those because for the benefit of take-home messages for either embryologists or clinicians who are just starting off in their practice, and if they are finding a high amount of implantation failure, just for them to know that the technique of embryo loading and embryo transfer can have an impact as well from that point of view.
But having said that, we have to give a disclaimer, Dr. Sulba and Dr. Manisha, with all due respect, that this will not constitute the actual definition
of RIF.
Yeah,
Yes.
yeah. We have overruled that and come to a certain stage
Yeah.
to be called a case of RIF.
Yeah, yeah.
But still, it's very important the way you both have discussed.
Thank you. So we come to the next case, which is a case of repeated implantation failure with mosaic embryos. So here is a 39-year-old woman with a diminished ovarian reserve. She has done 4 IVF cycles for pooling, and every time she has only ended up with mosaic embryos, no really euploid one. She has done 2 embryo transfers and both have failed. So what would you advise next? Anyone who would like to take this? It could even be one of the embryologists because this is about mosaic embryos. Abhinav, are you around?
I think nobody is there.
So I think Dr. Banker had explained very nicely in his talk regarding mosaicism and when to transfer and when to go in for maybe a donor cycle. So if she has already she has 2 failed transfers with the mosaicism. If it is a low mosaicism, yes, maybe we'll transfer the remaining 2. If it is a high mosaic, maybe going for a next cycle or maybe counselor for a donor cycle.
What about couple
Before going for a donor, I would like to get a karyotyping done for both the partners.
Couple, both the
Because
partners.
there must be some or other cause which is creating this problem, and that has to be ruled out.
So, Manisha, nowadays we have got very good genetic counselors.
Right.
So they can actually build up the family tree.
Right. It may be a
Actually
case of
come up to a
consanguineous
generation where they find repeated abortions or some sort of obstetric history which can correlate. And remember, once the parents' karyotype shows a balanced
translocations which
or
cannot be picked up
shows
by
structural
PGT.
rearrangements, then that can actually be done, except if you are lucky a good PGT find or a donor gamete.
But ma'am, having said that, that karyotyping has to be done from a very, very authentic and expert lab, because most of the time they are being done very casually and they don't give the right report. Most of the time we are saying they are normal, but they are not normal.
Absolutely. That's why ERA is coming receptive every time.
Right.
Why is ERA coming receptive every time?
Right.
So the commercial angle to any test will always skew the results.
But such kind of cases are definitely to be subjected to subjective to a genetic counselor, or a basic preliminary investigations are required.
Maybe down the line after 10 years, when Manisha has become chairperson embryology ISAR, we will have, ISAR certified labs. It's a dream to have ISAR certified labs, at least 20 in India, wherein every procedure will be, protocol based, fixed price, and you are sure of who is doing it and the results. Then we'll not have to rely on X, Y, Z, ye lab acha hai, wo acha hai, ye types,
Right.
So remember, Manisha, when you become that, huh?
Ma'am, please, that is never my dream. I'm just happy with the process of learning and working with you all.
Dr. Manisha. So
No.
the next question was a little bit more interesting angle to this. Now she has one remaining embryo that was reported as no DNA detected, so it was not transferred yet. So what are the lab's views on rebiopsy or reevaluating such embryos? What does it mean?
The
Why
next
does it
slide.
happen?
Can we have the next slide? Oh, actually, she has one remaining embryo. Okay, in the same. Okay, that was reported.
No DNA detected. What should be done? She doesn't want to go for a donor cycle. She's saying, what about this embryo? Would you like to rebiopsy it? What are the cases where you typically get no DNA detected? Why does that happen?
So any embryologist, whether they would like to take.
Dr. Anant Lakshmi.
Dr. Anant, acha, Sejal is there. Ha, Sejal, go ahead.
So yeah, I actually has faced such a case where we had got almost all low mosaic and one aneuploidy. So we had a decision of taking a rebiopsy of that patient. The first PGT we had done a non-invasive, so we could go for a biopsy, and the biopsy gave us one euploid. In another case, we had already a biopsy done by some another embryologist, where again we had got insufficient DNA content. So we had got a rebiopsy done where again we found a euploid embryo and that was been transferred. I don't know about the results, but of course there was a difference in the results that we got. So I think that at least gave us a little ray of hope that
Yeah.
something good can happen.
So no DNA detected we get most commonly in either if the number of cells was less or they could not amplify the DNA, or if it is a grossly complex aneuploid embryo, even in those cases.
And
Ma'am,
there's one more
basically the error,
cause.
if it is less than 10 kb, then none, either the biopsy or the non-invasive test, they are unable to process it, and that's why either they gave a low content of DNA or so. So basically, it's a blind embryo or a blind blast, which is not
And,
tested.
apart from that, poor storage and poor transportation can be the cause. So you have to be very, very cautious. While biopsy can be good, but their storage and transportation should be done very, very carefully. That is
Manufacturer's guideline regarding how the biopsy has to be,
done.
first of all, done, stored, and transported is also very important.
In case of very precisely, in case of no DNA detected, if embryo quality is good, we can very well go for the rebiopsy of the embryo.
And we have cases where they turned out to be euploid on the next review.
Yes, yes, very well.
Especially for patients not willing for a donor cycle, I think it makes.
And before putting them for a donor cycle, we should give them this option. When they can become their a biological parent, then why not?
Right, absolutely. And then this is the last case about sperm DNA fragmentation. The male partner, he has a borderline high DFI, 30 to 35%. All the embryos looked good but failed to implant in 2 cycles. So should we involve the lab in choosing the sperm via Pixie, Max, or any other advanced sperm selection technique? Would that improve the implantation potential?
First of all, what is the technique that is being used for DFI? And
So
how is 30-35 normal?
Yeah, no, it is not normal. That's why I'm saying it's
borderline. They are saying
Borderline high.
borderline.
Borderline high. But
Borderline high.
what technique is being used, that is also important. Because
Right.
different techniques give you different levels of DNA fragmentation, and
Like
they have
so-
different cutoffs as well.
So consider as per that like manufacturer's protocol, it was in a borderline case. So now readily kits are available which are being used. So in such scenario, what would be your answer?
First of all, treat the patient. Do a pre-IVF DNA fragmentation index for patients, especially who are above the age of 35. A DFI should be done for them. Patients who are at high risk of lifestyle practices, smoking alcohol, or have grade 2, grade 3 varicocele, in such patients, DNA fragmentation should be done along with semen analysis. Treat them for a minimum of 3 months, reevaluate them for DFI. If it has decreased, go in for conventional. If not, then you can have a modification of sperm preparation techniques. Maybe max can be done. There is microfluidics that can be done, which can give you good sperm, good motile sperm, at least a good motile sperm, a good looking morphologically motile
No
sperm can be
ROS.
given.
low ROS. But
Yeah.
here, Dr. Sulba, I would like to take one point, I would like to emphasize on one point. Generally, we are doing DFI on unprocessed sample. If
Yes.
you have done a very good
Post-wash
post-wash DFI is automatically, if it has been handled nicely, it is going to be very, very low. So rely on post-wash DFI. And second thing, still, if it is a high lifestyle modification can be helpful, but it is gonna take 3 to 4 months, and you have to recheck if patient is not ready to wait. In comparison to Pixie, I think Max is, in my own experience, Max is giving us better quality of sperm and better fertilization rates. If it is not working in that worst scenario, there's no harm trying anything.
And what are the cases where you think a testicular sperm retrieval would be preferred?
That is again very, very, before going for testicular sperm retrieval, I would like to go for a second semen sample.
Yeah.
That can also be helpful to reduce ROS impact on the semen parameters.
Yes.
And in case if there is a very, very poor mortality or a total teratozoospermia, such cases, you can, and in case of cryptozoospermia with very poor sperm parameter index, then in such cases, we would rely upon the testicular sperm.
So testicular sperm, I would go in when there is an oligospermia and a teratozoospermia.
Teratozoospermia.
So oligospermia, yes, if the count is less than 1 million, which is
Forget about
generally seen.
oligospermia, Amok. In oligospermia, I'm talking about cryptozoospermia.
Yeah. Even in cryptozoospermia, especially you need to take the history of the patient, whether he's a long-term diabetic, a type 1 diabetic. In such patients,
Right.
there can be cryptozoospermia, there can be sperm you can retrieve from the urine sample as well. And sperms are generally not that great. So in such cases, it is always better to go in for a testicular biopsy.
What
Even
is your take on grade 2, grade 3 varicocele patients?
So grade 2, grade 1, grade 2 can be managed by medical management. Grade 3, grade 4, a laparoscopic varicocelectomy should be done. Not an open, a laparoscopic one, because you can see the magnified view of the blood vessels, the engorged blood vessels, and selectively clip them. The open one had a problem that many times even the seminiferous tubule, the vas difference was also clipped or ligated. So laparoscopic one generally does not have that problem.
So in my practice, because testicular sperm retrieval is invasive, we don't, of course, tell everybody to get it done, especially when you have the option of using antioxidants or advanced sperm selection techniques. But typically in patients who have got a very low sperm count or motility, because in them, if you use max, you will get nothing out of it after the max has been done. Plus, in people where the DNA fragmentation, sometimes we get as high as 70 or 80%. Even then, you wonder after the advanced sperm selection, what is going to be left to use. And in such cases, especially when you have a low count and motility, sometimes you get nothing on TISA also. So what we do the morning before TISA is we take 2 sperm samples at the gap of about 1 hour, and then we do the TISA. If we get TISA sperms, preferences to use that. If we don't, preferences to use the second sperm sample, because that was at a very, very short abstinence. So it would ideally have less, amount of DFI. So that was the last case, and now we'll come to some rapid fire questions. Let's take them one by one. So single most underrated factor in implantation. It's
lab quality.
Okay.
Lifestyle.
Lifestyle. That is very true.
Lifestyle, yes.
Lifestyle. Dr. Neeti, if you could add one test to the standard RIF workup, what would it be? What is the one most important thing that you should be testing?
Karyotype.
Okay, karyotype is a
Ma'am,
good.
I would say genital tubercular testing.
That's also a good answer. Dr. Monica, any expert comments about that? One test that you would do in your standard RIF workup.
Hysteroscopy.
Yes.
Okay.
That is in fact in the green. So yes. Then one lab parameter that deserves more clinical attention. Any of the embryologists?
More clinical attention. So, I
And
mean,
then it would have an impact on the clinical outcomes. One lab parameter that you think should definitely be looked into.
I always believe in Cairo consensus, which says if you talk about one thing which is very, very important in IVF lab is everything. I really wanted to put it. So
Of
each
course.
and everything is
Of
very
course.
important.
Yes, yes. Nothing can be overlooked. It's such precise work that the embryologists do. Freeze all or fresh transfer in an RIF. I think this
These
got
all.
discussed,
Yes,
so we'll skip
really.
that. Endometrial receptivity or embryo competence, what matters more? I think
Embryo
Both go
competence.
hand in hand.
both go hand.
Yes,
Right.
yes.
Okay. So that actually brings us to the end of this discussion. And then we would just like to conclude the whole talk by saying that this dialogue has mainly reinforced that implantation success is not just about the embryo or just about the endometrium. It's more about synchrony, communication, and continuous fine tuning between both the lab and the clinic. It also depends on lab parameters, it also depends on patient parameters, and it can't be approached as a solo diagnosis. It has to be a shared responsibility. Dr. Manisha?
But the same things I'm going to repeat. Implantation success lies in details. You should note down each and everything. Morphology alone can't predict implantation in RIF. Dig deeper. Considering PGTA or NIPGT selectively, not routinely. Evaluate invisible lab stressors and transfer timing strategies. Even a high perfume in your lab worn by the clinician can impact your transfer. So keep the dialogue open in very respectful, transparent, and harmonious way. And that is the secret of the success. And with patients as well.
So, of course, we have to choose the best seed, get the best soil, transfer at the appropriate time. And I would like to end it with four of my favorite quotes. Two Dr. Banker already mentioned, but I normally say this also when I talk about RIF, that firstly, that we cannot keep doing the same thing again and again and expect different results. That would be insanity, as Einstein has said. But when we are trying something new, the main thing to keep in mind is primum non nocere. Try the empirical therapies, even if they are not backed by evidence, as long as you're sure you're not making it worse for your patient, because we do know that any sufficiently advanced technology is equivalent to magic. And just as Dr. Monica concluded in her talk, that the main thing is empathy. These are the patients who are at rock bottom suffering. They are going through grief. They are grieving the loss of an imaginary child that they could have had. So the main thing to keep in mind in cases of RIF is, this is my favorite quote by Carl Jung: know all the theories, master all the techniques, but as you touch a human soul, be just another human soul.
Beautiful.
Thank you.
Beautiful. So
Thank
beautiful.
you. Thank you. Thank
And
you.
try, if you are having that connect and that empathy with the couple, then very much likely that they will continue that successful IVF cycle with you, which might be the fifth one, which might be the fourth one. But they will persist. So every cycle you have a chance of becoming better because you're already very good.
Right.
So you can only become better. So the patient has to understand that she can trust you completely only when you have that connect. It's difficult, but it is possible.
Yeah. Very well said, ma'am. It is rightly that same things were concluded in Dr. Manish Banker's talks, that more attempts will give us more success, even repeating the same technique.
So I think that brings us to the end of this webinar, and it reminds me of Perfection series of 2023, where we used to continue for 4 hours plus. So as of now, we are 10 minutes, 8 minutes past 9, and it's 4 hours. I could have my dinner in between, but I know you all must be, hungry and tired and everything. But it was a very fruitful webinar. I'm so thankful. And I think I had a question that, Madam, so many panelists, why have you selected so many panelists? Manisha invited Garima invited, I invited from Bhopal. But see, at the end, how many are left?
Yeah.
The ones who joined out of 15 were hardly 10. And out of 10, only 5 are remaining at the end. So I think we have persisted.
Yeah, I think Dr. Monica, that is the reason for selecting so many, because last minute some are not able to join or some have to leave midway. So when you
Yeah, and they can come in waves, like waves of folliculogenesis. Keep coming and going. You know, the ones who come, they ovulate, and the rest can go in the background.
Thank you so much.
But I would like to thank Manisha ma'am for giving me this opportunity to join.
Really, really
Thank
happy.
you.
Thank you,
Dr.
Manisha
Manisha,
ma'am,
for
for
giving
the
us this
opportunity. Thank you
Thank
so
you.
much.
Thank you for the
Amazing webinar.
wonderful panel, Sulbha and Manisha. You both were fantastic. And thank you for all the inputs. All of you, Amog, Neeti, Jaisal, Gunjan, Sejal, just extraordinary. Ananta and Garima could make it despite that little bit of panic situation at home. And everything just went on very well. And I thank our studio partners, BSV team, BSV, Anmol Singh Chauhan, and of course, the BSV team, Priyanka and Rubia. Thank you so much for being there, all of you.
Thank you so much, ma'am.
Thank you.
Thank you, ma'am. Thank you so
Thank you,
much.
ma'am.
Thank you so much.
And
Thank you.
thank you to all.
Meet again for Perfection Fertisphere 4.0. We'll be deciding a date for the third week of August, and we'll be intimating that date and topic very soon to all of you. Thank you so much.
Thank you.
Thank you. Thank you all. Good night.
Good night.
Good night.